Turning it on right now. So welcome to the June Pharmacy and Therapeutics DOR board meeting for the Oregon Medicaid program. As I just mentioned, this meeting is being recorded. We do have all of our committee members that are in attendance, so um, we welcome you. And as Sarah just mentioned, if you're able for the audience, please add your affiliation after your name. That way we can accurately record who is in attendance for this meeting. So with that, we are going to get started with roll call and introductions. Just to call out at the beginning, I am happy to announce that we have a newly appointed member. She will be here at the bottom of the screen and get to introduce herself to the committee. But we welcome Samara Stevens as one of a public appointees. And so with that, Doug, let's let you lead off.
I'm Douglas Carr. I'm an internist by training, currently medical director at Umpqua Health, CCO in Douglas County, Roseburg, Oregon.
Welcome, Doug.
I'm Russ. Yeah, I'm Russ. I'm a psychiatric nurse practitioner at Salem Health in Salem.
Appreciate it, Russ.
I'm Eriko Onishi, OHSU Family Medicine.
Welcome, Eriko.
Hi, Eddie Saito, Associate Professor with Pacific University School of Pharmacy and Clinical Pharmacist with Virginia Garcia.
And I'm Pat DiMartino. I'm faculty at OHSU, where I'm a peds hem-onc doc.
Welcome, Eddie and Pat. Kat was not able to join us, so Tim, will turn it over to you. Oh, sorry, Stacy, I skipped you.
No worries. I figured you would circle back. Hi, everybody. I'm Stacy Ramirez. I'm a faculty at OSU College of Pharmacy and a primary care pharmacist and director of pharmacy at the community health centers of Benton and Lynn counties.
All right, welcome, Stacy. And Tim, I tried to put you on the hot seat, and now I understand your mic is not working. So Tim Langford is the pharmacy director with Klamath Tribes down in Klamath Falls. He's one of the pharmacist representatives. Appreciate you being here, and we'll see if we can rectify your mic issue. Bridget, we'll turn it over to you.
Yeah, my name's Bridget Bradley, and I am a clinical pharmacist in primary care at OHSU.
Excellent, welcome. And Dr. Stevens, we'll give it a little more a moment of introduction just because you're new to the committee, the staff as well. So welcome.
Thank you. Hi, there we go. Hi, I'm Samara Stevens. I am a naturopathic physician up in Portland in private practice at Holistic Mental Health. And I am very excited to be here today and to be participating in this. I work primarily with eating disorders and mental health, but also quite a bit of diabetes management as the consequences of eating disorders do tend to spill over. So I'm excited to participate in what the committee has to offer to Medicaid patients that need good access to care.
Well, we're excited that you are willing to join the fray with us and that the OHA appointed you. You are in a public position. But again, if you have questions throughout the day, please chime in. We welcome those from the committee at all times. Or if you have ideas for things that we might pursue with DUR initiatives, again, we welcome those. So welcome. Appreciate you being here. Tim, I'm going to circle back to you, see if we've got your mic issue fixed.
It appears that it is working. Thank you for introducing me, Tim Langford, Pharmacy Director with the Klamath Tribes, and I'm glad to be here today.
Welcome, Tim. Thank you. Now we'll turn it over to staff for introductions.
Jennifer Bowen with the Oregon Health Authority. I'm the Executive Assistant.
And I'm Roger Citron. I'm the director of the Drug Use Research and Management Program. So we provide clinical support to the OHA. We're affiliated with Oregon State University, but dedicated to our work with the Oregon Health Authority. And I am going to go off cameras because it's very distracting.
Hi, everybody. This is Trevor Douglas. I am the Pharmacy Policy and Programs Director at the Oregon Health Authority. Thanks for being with us today.
Hello, I'm Dave Engen, clinical pharmacist with the OSU Derm team. Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators with the Durham team.
And I'm Ann Kibler. I'm the clinical pharmacy manager at OHA. I also have a small faculty appointment with the Durham group at OSU College of Pharmacy.
My name is Kyle Hamilton. I'm the pharmacy drug coordinator here at OHA.
I'm Megan Herring. I'm a clinical pharmacist with Durham and the College of Pharmacy.
Good afternoon. I'm Deanna Moretz. I'm a pharmacist with the OSU Durham team.
Hi, I'm Kathy Centena, and I'm also a pharmacist with the OSU Durham team.
Hi, my name is Sarah Servid. I work as a P&T clinical co-coordinator with the Durham group.
I am Lance Starkweather. I'm a pharmacy manager with Gainwell Technologies.
I'm Dee Weston, Deborah Weston go by Dee. I'm the pharmacy program policy advisor with OHA.
Brandon and Ted are not able to join us today. Michael, we just added you on here. We might have to find out if we have any other titles to add to you, but we'll turn it over to you.
Hi, everyone. Thanks, Roger. My name is Michael Yu. My pronouns are he, him, his, and I'm the community pharmacy liaison for OHA.
Welcome. So next is, we're going to follow along on the agenda. We'll have that up on the screen. We'll be posting materials and presentations throughout. For your information for the audience, if you wish to follow along, on our website, we had posted the packet of materials along with written testimony and a letter from the OHA. So just wanted to bring that to your attention. As I mentioned at the top of the order, this meeting is being recorded, and within a week after the meeting, we'll have that posted, get some minutes out and the recommendations. Next up on the agenda, as you're following along, is conflict of interest declaration, vitally important to the OHA for transparency. All of the OHA staff, all of my team that are contractors and Glenn have conflict of interest declaration on file with the OHA, as just do all of the P&T committee members. So we keep those up to date, make sure we keep the P&T, keep the OHA appraised of any conflicts. And if there are any that pop up during a meeting, if we have a topic that a committee member wishes to recuse themselves, we expect that they'll do so. We also require that anybody wishing to provide public comment to the committee fills out a conflict of interest declaration. Generally, if it's industry, the committee understands there might be a conflict. If it's public members, I will call out to the committee if there's any other conflicts the committee should be aware of. So with that, we'll just see if any committee members need to disclose any new conflicts to the OHA before we proceed. All right, hearing none. Next, we have the approval of the agenda and the minutes. The minutes are found in the packet of materials starting on page 4. So we'll turn it over to the committee to see if anybody has any edits to those minutes. If not, need to get a motion to approve.
So moved.
Thank you, Doug.
Second.
Thanks, Eddie.
All those in favor?
Aye.
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 Aye. Opposed? Abstain? Thank you.
Next, we're going to turn it over to Andrew for the department update.
Thank you, Roger. The first thing I'd like to do is just read the response of OHA on the coverage of weight loss drugs under the Oregon Health Plan. That right now is presently available on the OSU Durham site beside the meeting packet. But I would like to read that to everyone on the committee right now. It says, after careful consideration, the Oregon Health Authorities decided not to extend coverage of weight management medications, including GLP-1 receptor agonist medications, specifically for weight loss in adults under the Oregon Health Plan at this time. The decision was difficult. OHA recognizes that using weight management medications and support members who have struggled to lose weight traditionally. However, the cost of covering these medications would exceed current service level budgets and require additional and significant investments from the Oregon legislature. Due to current revenue forecasts, this budget request was not put forward for consideration in the governor's budget for the 2025-2027 biennium. The legislature will have the opportunity to consider investments for weight loss medications in future legislative sessions. OHA is committed to continuing the valuable work around this issue, and we hope to see reductions in costs related to weight loss medications, making them more financially attainable for interested Oregonians and coverage expansion. We appreciate your willingness to share your thoughts and experiences, and please continue to share them through public comments in person or in writing. Your feedback is essential as OHA continues to work toward a solution for Oregon Health Plan members. I would also like to share with the committee and I will take comments or questions from the committee in a second. I would like to just comment on the mental health clinical advisory's work so far in 2024 as they advised this committee on mental health medication coverage, treatment coverage for mental health disorders. They have published two documents so far in 2024, and you can see those on the webpage under recommendations under the Mental Health Clinical Advisory Group recommendations section on their webpage there. The first one is recognition and management of antipsychotic-induced movement disorders. And all their recommendations, they cover acute dystonia, acute akathisia, Parkinsonism, and then tardive dyskinesia. And all those recommendations are in alignment with the Medicaid fee-for-service criteria. So, but for your interest, I would encourage everyone to look at that. The second document is treatment of schizophrenia with antipsychotic medications, which is an update from 2019 to which continues to emphasize long-acting injectable second-generation antipsychotics and presents a couple of treatment algorithms for both second-generation and first-generation antipsychotic use, and would also encourage you to look at those. Those are also in alignment with the criteria for Oregon Health Plan fee-for-service. So other than that, from a clinical perspective, I don't have anything more to share. I don't know if Dee Weston has anything to share, but I will open it up to the committee for any questions.
This is Eric Onishi. I just want to make sure I understood that. So Medicaid patients are not covered GLP-1 to agonist for obesity? Is that what I heard?
Yeah, adults are the coverage of all weight loss medications, specifically for weight loss in adults, are not part of the state state plan for Medicaid, and we will not amend that state plan to include weight loss drugs at this time.
I am very shocked and very sad as a primary care physician. What's the next step for this?
The next step, according to OHA, is to find money for it. Basically, utilizing the legislature to find funding for these medications, which the state currently doesn't have the money to fund.
But also the obesity causes so much issue, including mental health and all that stuff. So I'm not sure, and
yeah, from a clinical perspective, everyone I think agrees with you. They are very helpful and very effective. That's unfortunately not the problem.
Okay, I'm just shocked and sad.
Appreciate that, Dr. Onishi. And again, just to clarify, the GLP-1s are covered for diabetes, and the weight loss medications are covered under EPSDD for members under 21 years of age. So just wanted to clarify that. But to clarify and put a point on it, Andrew is saying it's for adults. Weight loss in adults is not part of the Oregon state plan.
Thank you for clarification.
Doug, did you still have a question for Andrew?
You clarified it for me. We had it approved for diabetes and for EPSDT, and we'll continue for those conditions.
Correct. Appreciate it, Andrew.
Yep.
All right. As I mentioned at the top of the order, the P&T committee also serves as a DUR board, so we'll be focusing on some DUR activities. One of those is the quarter utilization report. We make that as part of the consent agenda. Those are posted on our website. If you're looking in the packet, those start on page 9. We also have some scans of information. In this case, when a scan is included on the consent agenda, there's no new clinical information to be considered. Really, we are going to be bringing this to executive session to be looking at some pricing. And in the case of oncology PA updates, we do oncology. And if there are new agents for orphan drugs, this is just lets us have a streamlined process to apply them to our policies so that we hold them to label for coverage. Don't have any public comment, but can leave it to the committee if any of these topics you wish to discuss. And if not, we'll just revisit a couple of the topics in executive session. So hearing none, we will focus now on our DUR activities. So if you are, again, following along on the packet of materials, we're on page 87, and we'll turn it over to Lan with Gainwell for the ProDUR report.
Thanks, Roger. So this is the high-level summary of the DUR, the prospective drug utilization review prior to a medication being dispensed. On the left side shows the different alert types. The second column just shows the different examples of what might trigger those alerts. And then the third column just shows whether or not the claim is set to pay or deny, and then the number of alerts for the quarter. So overall total for first quarter of 24, we had 163,000. The two alerts that are set to deny the claim is the early refill. So this is when the patient's trying to fill prior to the 80% threshold. So we had 104,000 alerts for the quarter. 22,000 was overridden. And then that translates to a 21% override. And then the other alert that's also set to deny the claim that requires a pharmacist intervention is the pregnancy drug interaction. We had 18 for the quarter, 15 were overridden, and that's an 83.3% override. Next page. This is just a breakdown of the top drugs that are enforced when the prospective DUR. I've broken it down to the different categories. The primary ones that we see are the carve-out drugs, so the antidepressants and the antipsychotics. About 1 in 5 prescriptions for SSRIs are overridden. If you can see the last column, about 20%. And then for antipsychotics, we have 1 in 4 prescriptions that are overridden for that drug category. Next page. Here is the different reason code for the alert. So this is what the pharmacist will enter in for why they would need an early refill. Overall total for the 3 months is 15,478. A majority of that has to do with submission clarification 7, medically necessary. So that's 73.4% of the prescriptions were overridden for that reason. We have 13% for submission clarification code of 5, which is a therapy change. And then a 5% for lost medications. Next page. And then lastly, this just shows the cost savings for the prospective DUR. For the month of January, we had $891 saved to the state. February, 106 total prescriptions were not dispensed, so cost savings of 28,000. And then for March, only 5 prescriptions that were not dispensed. So that's a cost savings of 520. So overall total 29,684.37. Any questions on the ProDer?
Is that February number anomalous?
No, some months tend to have more alerts depending on the prescriptions that are dispensed by the pharmacy. And then some will try to dispense early for various reasons, whether or not patients are going on vacation. There's patients who are out of school and needed for the summer. But it kind of waxes and wanes, so it's not really an anomaly compared to prior years.
Thanks.
Any other questions on prospective DUR? Great, thank you, Lan. Next, we'll look at retrospective DUR, starting on page 91 in the packet, and turn it over to Dave.
All right, thank you, Roger. Yeah, for the latest retro DUR report, we're looking at Q2 data. So that's January through March of 2024. And I'll just hit the high points of this report. On this page, you'll see the initiative Billing Correction Review. This is to help us review claims with other insurance that might have been billed incorrectly. So for clarification, OCC stands for Other Coverage Code. And so this report is trying to look at coordination of benefits, and it's giving us baseline data to make sure that Medicaid is the payer of last resort. And this report is still undergoing some tweaks, but as we gather data, we'll report it back to you and see if there's new opportunities that come out of this. So more to come on that later. On page 92, we see our change forms. We've got aripiprazole, desvenlafaxine, and venlafaxine. And we're seeing continued opportunity with providers changing more cost-effective formulation of aripiprazole. That's about 12,000 in savings reported for that quarter, and that number will increase as we capture the savings impact over 12 months. So you should see that going up quarter over quarter. The desvenlafaxine and venlafaxine change initiatives, they're not quite as impacting as they were in the past, but we'll continue to run them in the background and then we'll also be looking for new opportunities. But those also do accumulate month to month. So we're still generating savings from those. Page 93. This captures our messaging to prescribers about dose consolidation. Nothing significant to report, but once again, most of the messaging is going on at point of sale now. Page 94. This is our expert consultation referral for long-term antipsychotic use in kids. Lots of patients screened, but relatively few are flagged as high risk. But those who are, the prescribers get a referral to Opal K for a consult. So see the numbers there. And then page 95. This is our messaging to prescribers about patient non-adherence to their antipsychotics. And those numbers are almost identical quarter over quarter, it seems. We're seeing nearly half the patients refill for an antipsychotic within the next 90 days after their prescriber was notified. So feel that that is continuing to have an impact. On page 96, so this lists the different individualized profile reviews for children in foster care, as well as for patients with a variety of high-risk conditions. We've got bipolar, polypharmacy, chronic opioids, and those types of things. So as I've stated before, we send letters to the prescribers with customized recommendations if there are safer alternatives available. And those numbers stay pretty consistent quarter by quarter. Page 97. This is our safety net program for antipsychotics in really young children. in this case, if we know PA is ending, we proactively notify the prescribers to submit a new PA for their patient and then tell them what's going to be required so the patients get appropriate care with no interruption in therapy. Seeing a slight uptick over last quarter, but once again, pretty consistent with previous quarters. And lastly, on page 98, we report this safety net monitoring. The first one's for patients on dangerous opioid sedative combinations. And there's actually a downward trend in prescribing from the previous quarter. In fact, it had spiked around 150 patients a few quarters ago, and now down to about 100. Now we're identifying 80 patients. So that's good news, and especially because roughly a third of those prescription combinations are being discontinued. So that's having an impact. Also, you can see we notify prescribers if a patient's been denied an oncology med with no evidence of a new fill for an alternative agent. And then we do the same thing for prescribers whose pediatric patients were denied a TCA, but no alternative was filled or requested. And we've got, once again, similar numbers to the previous quarter. So yeah, that's about it for the RetroDur report. Once again, please let us know if you think of or hear about any new opportunities in this space, and we can definitely investigate those and possibly work it into the lineup if it looks promising. But there's no other questions. I'll turn it back to you, Roger.
Appreciate it, Dave. Any questions about retrospective DUR or the initiatives we take action on? All right. Another component of drug use review or DUR that's mandated is education. One of the ways that we accomplish this is through our Oregon State Drug Review newsletters. And turn it over to Kathy Centena, who's our editor, to talk about a few of the most recent publications.
Great, thanks, Roger. So today we'll be briefly recapping two newsletters. The first one was published in December of 2023, and it was a newsletter on opioid reversal agents. And this newsletter discussed the different types of reversal agents, prescription status, and then their role in reversing the new potent synthetic opioids. The second newsletter was published in January of 2024, and it was an update on insomnia, as well as the evidence and Oregon Medicaid policy. This new newsletter summarized the evidence for insomnia treatments and describes new policy changes for Oregon Medicaid. Again, thanks so much to the authors who assist in providing these important provider education pieces, and to the committee for continuing to provide feedback and suggestions. I'd also like to give the committee a chance to recommend any new topics that they think might be of interest to our providers. And you can always email us as well if a topic comes to mind. We're open to those and appreciate those as well. And then if you aren't receiving our newsletters and you'd like to, you can go to our website.
Kathy, you just cut out. So she was mentioning on our website where these materials are posted. We encourage you all to subscribe to our listserv. You'll have an opportunity to sign up for which portions of materials you receive. Those can be the draft and final documents we post, as well as when we publish our additional newsletters going forward, you will receive those in an email. So Kathy, sorry we lost your... so we'll move on. Oh, there we got you.
Yeah, no, I'm here. Sorry, I don't know if it cut out, but yeah, thanks, Roger. Appreciate it.
All right. So now we're going to move on to a DUR new business. We'll turn it over to Sarah Servid, and it starts on page 107 in your packet.
Thank you. I'm going to be talking today about an ADHD drug policy evaluation, and this is mostly going to be focused on off-label use of ADHD drugs, so primarily for conditions other than ADHD. And this is going to be a brief overview. There is a significant amount of more information in the packet, so feel free to review that at your leisure and ask questions about it if you have them. So drugs for ADHD have been around for a long time and have been studied for a variety of conditions. Some of those are listed here. They include autism, learning disabilities, disruptive behavior, eating disorders, tic disorders. We, in fee-for-service, really only review requests for ADHD drugs or stop claims from paying when drugs are prescribed at doses above what's recommended in FDA labeling and current guidelines, for ages that aren't recommended based on current evidence and guidelines, or for combination therapy that's not supported by the current evidence. And so non-stimulants for ADHD are all paid for primarily by fee-for-service. Stimulants, on the other hand, are primarily paid for by CCOs for members that are in CCO, although fee-for-service does cover stimulants for members that are only in fee-for-service. So there's a little bit of a divide in what fee-for-service pays for. And so you'll see that represented in the claims data that I'm going to show you here, in that most of our use is for non-stimulants because those are carved out of CCO utilization. Currently, our prior authorization criteria supports use only for ADHD and narcolepsy. So it denies requests for off-label use of these medications. And this was an update that was made at the beginning of 2023. And so this analysis is looking at what that PA change did for our utilization, looking at what are the common off-label indications that people might be using ADHD drugs for, and how that off-label use might impact healthcare utilization. So the first part of this analysis was looking at members who were starting a new ADHD drug who did not have an ADHD diagnosis. So trying to identify people that were using it off-label for off-label conditions. We looked at a 6-month time frame for this analysis and identified a little over 600 members who were starting a new ADHD drug who didn't have an ADHD diagnosis. Most of them were adults, about 63%, and most were enrolled in a coordinated care organization. And that is why most of the utilization for fee-for-service is in the non-stimulants. About 90% of our utilization for what fee-for-service paid was for non-stimulant use. The majority, well, almost half of utilization was prescriptions written by a general practitioner. About 17% had prescriptions written by a psychiatrist, and the rest had prescriptions from some type of mental health specialist, and it was primarily mental health nurse practitioners. And so here you can see diagnoses that we tried to identify that had some evidence with supporting literature. We looked for guidelines that mentioned utilization of ADHD drugs, and there are guidelines out there that support use of ADHD drugs for people with learning disorders or intellectual disability, autistic disorders, and disorders with severe disruptive behavior like conduct disorder and oppositional defiant disorder. There are guidelines out there that say if the member has one of these diagnoses and symptoms of hyperactivity or distractibility, even if they don't meet the diagnostic criteria for ADHD, it might be reasonable to try an ADHD med to target those specific symptoms. There also is some evidence out there that tic disorders might be improved with some of the non-stimulants, as well as eating disorders for some of the stimulants, and narcolepsy and cataplexy. Some of the stimulant medications do have those FDA-approved diagnoses for narcolepsy and cataplexy. However, only 17–18% of the people had one of those diagnoses. most patients, we couldn't identify what they were using the ADHD medication for. And we did try and identify diagnoses that might be relevant as far as mental health diagnoses that these patients had. But the pattern that we saw for mental health diagnoses was very similar to the pattern that we see for people on OHP in general. So for example, anxiety disorders, severe stress reaction disorders, and major depressive disorders are very common for people on OHP in general. So it doesn't necessarily reflect diagnoses for why they're using the ADHD medication. And there were some differences that we saw across populations as far as diagnoses. So evidence-based diagnoses were, for example, more common in children and pediatric members. Members without those evidence-based diagnoses were more commonly adults. Clonidine and guanfacine were more commonly prescribed in people with evidence-based diagnoses, and people who had prescriptions written by a psychiatrist more commonly had an evidence-based diagnosis. So there were some variation in population as far as what diagnoses were prevalent. And then we also looked at healthcare resource utilization in the 6 months before these members were prescribed an ADHD drug and the 6 months after they were prescribed the ADHD drug to see if there were any trends in other healthcare resource utilization, and particularly emergency department visits, other prescribing patterns for other drugs, psychotherapy, and inpatient hospitalization. And we really didn't see any trends to indicate overt harms because of off-label prescribing for ADHD drugs. There was no difference in emergency department visits, other meds prescribed, or psychotherapy. There was maybe a small decline in inpatient costs over the 6 months following an ADHD prescription of an ADHD drug, but the differences were very small, and we had a small population to start with. So I'm not confident that ADHD drugs actually decrease inpatient costs, but we did see a small decrease there. And then the second part of this evaluation looked at the policy change that happened in January 2023. At that time, prior authorization criteria were updated to limit use to FDA-approved indications, particularly ADHD and narcolepsy. And then we modified the criteria to permit ongoing use of an ADHD drug for members who are turning 18 years of age. In particular, clonidine and guanfacine, extended release versions only have the indication for ADHD in pediatric patients, and off-label use generally isn't recommended for adults with ADHD for those particular medications. But at that time, if they had demonstrated benefit when they were less than 18 years of age, the criteria were updated to allow ongoing use when they turned 18. So for this analysis, we looked at the whole population of people who were prescribed an ADHD med where fee-for-service had paid for that medication. And so that included people both with and without ADHD. It included people who were starting a new ADHD and people with ongoing therapy. And we looked at 6 months before the policy compared to 6 months after the policy. Because guanfacine and clonidine are not FDA approved in adults, most of the prior authorization criteria applied to those two medications. There's little utilization for stimulants because CCOs cover most of them, and our other non-stimulants, atomoxetine, and primarily is a preferred product. So overall, the portion of people who had an initial denied claim was similar before and after the policy, which makes sense because the only update we made was to prior authorization criteria. We didn't change quantity limits or edits through the point of sale that would deny that initial claim. So that was similar both before and after the policy. However, there was some variability in denied claims based on subgroup. So for people who were really young, less than 5 years of age, denials were more common after the policy change. And for people with ongoing treatment, denials were less common after the policy change, which was one of the goals of this PA change. There was no difference that we could see in the proportion of people before and after the policy change that had evidence-supported diagnoses. And so when we looked at those people who had an initial denial, we looked 90 days following that initial denial to see what happened to those members. And people who had a paid claim for a subsequent ADHD drug did decrease after the policy change from 62% before to 54% after. In this after group, about 34% of people had a subsequent claim for a stimulant. 21% of people had a subsequent claim for extended release guanfacine, which might indicate that a prior authorization was approved for those members. Of note, 25% of people did have a subsequent claim for immediate release guanfacine, and that might indicate that for fee-for-service members, they just switched to an immediate release version, where we don't have prior authorization criteria, or the coordinated care organization paid for an immediate release guanfacine formulation for them because the immediate release versions are not carved out of the CCOs. About 10% of people didn't have a subsequent paid claim, but we were able to find an ADHD diagnosis in the medical claims, which does indicate some barriers to care with this prior authorization criteria. So in conclusion, the claims data does indicate that a small portion of people on OHP are likely prescribed non-stimulant ADHD medication for an off-label condition. We didn't identify any overt harms as a result of prescribing an ADHD medication off-label. And some of these off-label conditions do have supporting evidence and guideline recommendations for use. 68% of members with an initial denied claim did have a subsequent paid claim for a similar drug. So the majority of people are getting some type of ADHD medication after one of these denials. And of note, 25% of people, they switched to a similar medication that's available without prior authorization criteria, which indicates to me that this PA isn't doing a whole lot to shift utilization away from these medications. And then another 20% of people were subsequently prescribed extended release guanfacine, which indicates that a prior authorization was approved. And so based on this information, the recommendations that we put forward were to update prior authorization criteria to permit this off-label use, particularly of the non-stimulant ADHD drugs, if there's consultation with a mental health provider. This was based on the fact that a lot of the off-label conditions, even if there are guideline recommendations, are generally based on low quality evidence. Just that's the nature of off-label use. And so we thought that a mental health provider consultation might be of benefit in those situations. But then also to just remove age restrictions for the extended release clonidine and extended release guanfacine to permit that off-label use in adults. It hasn't been studied a lot for ADHD in adults, but we didn't see overt harms for prescribing in adults either. And when we presented these recommendations to the Mental Health Clinical Advisory Group this morning, they were supportive of removing administrative barriers for these medications, particularly the clonidine and guanfacine. And they thought even a consultation with a mental health provider probably wasn't needed, and to just remove prior authorization criteria for the clonidine and guanfacine altogether. So I'm happy to take questions if you have them or comments.
I definitely think, this is Russ, I definitely think that removing the age restrictions for the extended release clonidine and guanfacine makes sense. You're right, they haven't been studied extensively, but there is evidence out there that that they do work in adults much the same way that they do in kids. So I think it makes sense. Yeah, gosh, the off-label non-stimulant ADHD drugs upon consultation with the mental health provider, though, I feel like we don't have a great idea of what these are being used for. But I mean, I also feel like, I mean, Strattera and clonidine and guanfacine, they're not. They don't have the same level of risk and abuse potential that the stimulant drugs do. So I mean, I don't know that there's in terms of protecting the public safety, I don't know that there's a huge amount of risk if a person is on one of these medications and they are functioning for them in some way. I mean, there is evidence for things like major depressive disorder. There are specific subtypes where stimulant medications and things that work like it can have evidence of being effective. When you look at major depressive disorder as a whole group, including all the different types, they don't tend to be super effective. But people with lethargic depression, sleeping 15 hours a day and things like that, there's evidence that it helps with those, with those folks. So, I mean, I think there are use cases where it makes sense to use these in non-approved indications. And I mean, I always feel like, I mean, given that the risk is not huge for most of these medications, I feel like putting the barrier of consultation with a mental health provider, I mean, how many of us are there out there that are able to be consulted with, right? I mean, your primary care provider is in, much of Eastern Oregon may not have a mental health provider with whom they can consult. So, I mean, I think there's risk that, there are some of these people who may be benefiting that we will be taking these medications away from and then, be causing indirect harm to. So I don't know. I'm conflicted on that one.
This is Eriko Nishi. I'm also kind of wondering about this mental health provider consultation part. Especially, it just sounds like it's not significantly risky medication.
Yeah, I mean, we're effectively talking about Strattera, atomoxetine, right? I mean, clonidine and guanfacine, I would expect most of our, primary care providers and anybody else to know how to prescribe those. So, I mean, nobody's getting viloxazine. I mean, in this group, so, I mean, we're really just talking about Strattera, atomoxetine, which is not any riskier than Wellbutrin. So, I mean, I don't know. I don't know that we would need to have any greater barriers on the prescribing of it.
Yeah, and to that point, Russ, the claims that stop for prior authorization are mostly clonidine and guanfacine, because atomoxetine is preferred and people rarely prescribe it at doses above the FDA labeling. We rarely see requests that come through our prior authorization process for that. So it is available without a consultation generally. It's mostly this clonidine and guanfacine, and there is an immediate release version out there that people can get without PA that we see them using. So
yeah, and so I mean, if they can get atomoxetine without this consultation, then we're only talking about clonidine and guanfacine. Then I don't think we need to have them consult with a mental health provider, because, I mean, what am I going to tell them that they don't know about clonidine and guanfacine? I mean, I'm sure most PCPs probably prescribe clonidine 5 times more often than I do. So, you know, I mean, and that's, I mean, whether it's effective or not is secondary to the concern about whether it's safe. And if they can prescribe it safely, then I'm not concerned about, I mean, you know, if it doesn't work, I assume that they would stop it just like we all would. So, yeah, I don't think we need to have the consultation with the mental health provider.
Appreciate that input. Any comments from anyone else?
I'd just like to second that kind of removing the consultation with a mental health provider. I think it poses a large barrier, especially and what I've seen clinically is a number of patients that are turning 18 and losing coverage of their extended release guanfacine and were already successfully treated with it, but are now a few days older. And so finding a mental health provider, a different one to consult with, it's just becomes another barrier that prevents patients from getting their needs met.
Appreciate that. So I am hearing support for removing prior authorization altogether for extended release clonidine and extended release guanfacine. Particularly the 12-hour clonidine, which is a carve out, to make them preferred, which I think is how we would functionally do that, and then remove the age and client limits.
I agree with that. I think that sounds like a good strategy.
So do we have a motion to make those changes?
So moved. This is Russ.
Thank you, Russ. Second? I think I heard someone try to second.
I second.
All right, thank you, Doug.
All those in favor?
Aye.
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 So, sorry, just to clarify, so no consultation needed, right?
It's a great question. So in this case, no, for the immediate release or the extended release clonidine and guanfacine, that would no longer be required, and we wouldn't have those age or quantity limits. The question, I guess, in front of the committee is if we have polypharmacy, so or excessive doses, for example, of atomoxetine and maybe polypharmacy with a stimulant, would it be warranted to still have a consultation with a specialist? Remembering that the consultation could include just a call with OPAL or OPAL, in this case, if it's an adult OPAL. Russ?
Excessive doses of atomoxetine, it sounds like, are not.
They haven't been a problem.
Yeah. And that, I mean, that's because most people don't even get anywhere near 100 milligrams before they stop taking it. So, I mean, yeah, I mean, there's a reason we have dosage ranges. So, I mean, yes, excessive, doses above 100 milligrams of atomoxetine probably should be checked on by somebody. I mean, I don't know how much of an issue that is in order to necessarily need to put that into the criteria. Taking with a stimulant is not as risky as people think it is. I mean, there is some increased risk, but I mean, it's not. It's not. Like taking high doses of benzodiazepines and opiates at the same time or anything like that. I mean, again, I think, I mean, I don't see that there's, I don't know how many people are on, high doses of atomoxetine or at some point viloxazine and also on, a high dose of a stimulant. I would imagine it's probably not very many. And I mean, there is some risk of harm, but it's not huge. So, I mean, I don't know that we need to call those folks out. I mean, unless that number is, increasing.
Right. At this point, with the change that you just voted on, the only things that would stop for prior authorization would be a non-preferred stimulant. And in that case, if the member had a concomitant extended release clonidine or guanfacine that was available without restrictions, they already filled that, and now they're asking for the polypharmacy to do that with a non-preferred stimulant, that would, according to the PA criteria, be one scenario that would still require expert consultation if it wasn't being prescribed by a specialist. Is that okay? I think it's gonna be a small number, but
I think that seems reasonable. But I agree. I think it's going to be a small enough number that it shouldn't be a barrier.
right, just as the criteria are written with the changes you've just recommended, that's just going to be the residual scenario that would result in that question and that requirement. But otherwise, nope, that is not going to be the scenario with preferred extended release clonidine and guanfacine.
Yeah, I mean, if I was going to pick a subgroup of people to encourage to have a consultation, it would be folks on a combination like that. So yeah, I mean, I think that's reasonable.
Excellent. So I think we had the motion. We had the vote. I'm kind of missing on the votes today, so I apologize for being a little bit.
Did we have to vote?
I think we had a motion
Okay.
and a second, so let's take it just to be sure, Stacy.
Yeah, I think we maybe got through halfway. So all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, there we go. We're official now.
Fantastic. I appreciate that. Got to keep me straight here. All right, next we're going to turn your attention to page 156 in the packet of materials, and we have the Drugs for Weight Loss PA update. We'll turn it over to Kathy Centena.
Great, thanks, Roger. Yeah, so today we're going to be talking a little bit about semaglutide, but before we get into that, a little background. So as most of you know, that we did talk about the weight management medications at the April P&T meeting. Coverage for weight management medications for children and young adults under the age of 21 is covered under EPSD via prior authorization, as Andrew already alluded to, and that for adults, the coverage for weight management medications are not covered at this time. The focus for this meeting, however, will be evidence for weight management medication use in secondary cardiovascular prevention. So looking at that, semaglutide, as I mentioned, received an additional indication in March of 2024 when it was used when it is used in combination with a reduced calorie diet and increased physical activity to reduce the risk of major cardiovascular events in adults with established cardiovascular disease, as well as obesity and overweight. Now, diabetic patients were excluded from this trial. The evidence to support this came from the SELECT trial, and we're going to go into a little bit more detail on that in just a second. At this time, semaglutide is the only medication approved for this indication. However, cardiovascular trials are ongoing with tirzepatide. Sorry, can you hear me okay?
We can hear you, Kathy.
Okay,
Thank you.
yeah, it sounded like something else was coming in, so I just want to make sure.
I heard that too, so I think it stopped now.
Okay, was it my connection? Okay, perfect. Okay, so let's talk about the SELECT trial in more detail. So this trial enrolled over 17,000 patients that were randomized to either semaglutide or placebo. Adults 45 years and older with a BMI of 27 or greater and established cardiovascular disease were included in the trial. Semaglutide was started at a weekly dose of 0.24 milligrams and then titrated up every 4 weeks over about 4 months to a target dose of 2.4 milligrams weekly, which was obtained by about 77% of patients at 104 weeks. Looking at the specific baseline characteristics, we can see there that the mean age was 62 years, so just slightly older than what we see in fee-for-service. They were predominantly male. The mean BMI was 33.3, so indicating most patients, about 71.5%, were obese. The different cardiovascular diseases that they had to be included in the trial, most commonly was MI, you can see there, followed by stroke and peripheral arterial disease. Now, you can also see by the cardiovascular medications that most patients were on standard of care therapies that we'd anticipate, such as lipid-lowering drugs, ACEs, ARBs, things like that. And the mean duration of exposure for semaglutide in this trial was around 34 months. So looking at the
Kathy, you just cut out.
Okay.
Oh,
Can
just
you
back
hear
up
me
a
now?
minute just to say looking at.
Oh, okay. Sorry about that. I appreciate you letting me know. So yeah, so looking at the primary outcome is hopefully where I left off there. You can see the composite of the primary outcome was composite of death from cardiovascular causes, non-fatal MI or non-fatal stroke. This occurred in 6.5% of those patients treated with semaglutide and 8% of those patients treated with placebo, with an absolute risk reduction of 1.5% and number needed to treat of 67. So essentially 67 people would need to be treated for approximately 3 years to prevent one cardiovascular event. It's also important to note that the different composite endpoints were tested individually in hierarchical order, starting with death from cardiovascular causes. However, this did not meet statistical significance, and therefore the other outcomes did not have superiority testing performed. We do look at another important secondary endpoint, which was body weight change at 104 weeks. And you can see with semaglutide, the mean change was a decrease in about 9%. And then also I looked at this at about 6 months. This was done again about 2 years, that change, but even at about 6 months, patients lost an average of about 7% of body weight. Moving on to the next slide. So common adverse effects seen with semaglutide were typical with the GLPs: nausea, diarrhea, vomiting, abdominal pain, headache, fatigue, and dizziness. About 17% of patients did discontinue semaglutide due to adverse events compared to placebo. And you can see the exact numbers there, that last bullet point on the slide. And then at 39 months, permanent discontinuations were similar between the groups, around 26.7% for semaglutide and 23.6% for placebo. So then I'd like to go and talk a little bit more about what we're recommending for the PA criteria. Now, what we did is took that PA criteria that everyone saw and approved in April, and we went ahead and integrated the components of secondary cardiovascular prevention into that. So we'll I'll direct you there where we'll skip a few of the bullet points to streamline it. The only thing to note on this slide is that you can see the initial approval is up to 6 months with renewals up to 12. And this slide here is just a standard table that was included again in that April PA criteria, no changes, just the drugs approved for weight management and if they're improved in pediatric patients as well. And this next slide is just the table of the BMI cutoffs for pediatric patients. Just included for it to be thorough, but no changes. So unless anyone has comments, we'll skip over that. And then here you can see the PA criteria starts. In number 2, we ask if the patient is less than 21 years of age and 6 years in age and older. And if not, then to go to number 12. And so that's where I'm going to start today, because that's where the changes occur. Again, we can go over, over the whole criteria if anyone has any questions, but since there were no changes, we'll go ahead and start number 12 and go through that first. So here we ask if the request is for weight management with an FDA approved indication for secondary cardiovascular prevention. If so, if it's a continuation of therapy, we do request they go to the renewal criteria. If not, we ask if the patient's been screened for diabetes within the past year, and if they have an HbA1c or other glucose measurements indicating diabetes. And this is just to have those patients treated with the GLP-1s or the combination products, which have been approved for diabetic patients, if that's the case. So if they have been tested and they do not have diabetes, we ask if the patient's 45 years of age or older. If yes, then if they have a BMI of 27 or higher. And if yes, if they have established cardiovascular disease, again, similar to what was required in the trial, and if yes, ask if the patient has tried a weight loss treatment plan administered by a healthcare provider in the last 3 months for at least 3 months in duration within the previous 6 months. If yes, then we ask if the patient is currently taking semaglutide Ozempic up to 2 milligrams weekly and able to tolerate the medication. We added this in as Ozempic and Wegovy are the same molecular entity, and Ozempic offers a large cost savings. So we're asking that they titrate on that product just because there is also a very high number of discontinuations with this drug as well. So ensuring that they can tolerate the medication. If yes, then go ahead and approve Wegovy for up to 6 months. If no, we ask that they go ahead and do a trial of Ozempic as they titrate up, and hopefully that goes well for them, and then they can move on to Wegovy. And then going to the next slide, you can see is renewal criteria. And again, we'll start on number 4 as it applies to what we're talking about today, asking again if this is for ongoing treatment for someone with established cardiovascular disease or for secondary prevention. If yes, if they've lost and maintained a BMI reduction at 5% or more, and that comes from guidelines and the recommended minimal clinically important difference there, and that's where that percent came from. And then if yes, then has the patient been adherent to therapy? If yes, then we just ask if they're continuing with their weight loss program as well as diet as this is recommended in the labeling as well. If so, to go ahead and improve Wegovy for up to 12 months. And that's the proposed new and renewal criteria. So I don't know if anyone has questions on that before we move on to recommendations.
Kathy, I just have one quick clarification.
Mhm.
So let's say in that, in the question around have they been screened for diabetes? And
Mhm.
let's say they say yes, and A1C is, I don't know, 6.8 or whatever above the criteria. So, but they still meet criteria for the higher dose semaglutide. Are we still recommending, because they have diabetes, even though they would qualify for the criteria to get the 2.4 milligrams semaglutide, we're still going to direct them to go the lower dose route that's approved for diabetes?
Yeah, that's correct. I mean, we have good evidence, that Ozempic 2.0 prevents cardiovascular disease in diabetic patients as well as has renal protective effects. So I think that that's clinically appropriate.
All right. I just wanted to make sure that I was understanding that correctly.
Yeah, no, I appreciate that. And that's a great question. And yeah, that's a really good question, but that was kind of the thought process behind that.
Yeah, Kathy, this is Eddie. Along those lines, though, I don't quite understand how someone would get to criteria number 19, because if they were taking Ozempic for diabetes, wouldn't they end at criteria 14?
Well, if they were taking Ozempic for diabetes, they would be able to get that through the other PA criteria for diabetic patients. So they wouldn't be taking both. And again, clinically, there doesn't seem to be good evidence to suggest switching someone that's doing well from Ozempic 2.0 to Wegovy 2.4, that there's an advantage there. And so, yeah, if they're diabetic, there's currently not a pathway for them to get Wegovy 2.4 milligrams weekly.
Right. So I guess I'm confused how 19 is relevant then, because this criteria is for, as I understand it, for patients without diabetes, right?
Yeah, that's correct. Yeah, sorry if I misunderstood your question. Yeah, exactly.
So if they had diabetes, then in number 14, it would already be denied. So who would be, who would be taking semaglutide Ozempic 2.0 and not have diabetes?
Right. Well, we're just asking that that's just kind of a filter question to number 20. So that's why, so if they say, no, gosh, I'm not diabetic, I haven't had Ozempic, we'll say, okay, that's no problem. Go to number 20 and try Ozempic. I mean, we could word it so we could flip those if you want. But that was just the way that it was written, that like, okay, if you're already on this and stable, go ahead and get the Wegovy. If not, no problem, go to number 20 and you can. Does that make sense? Or is that still, is that still confusing? Like I said, we could flip them.
Can I ask a clarifying question? If somebody is going to be put on Ozempic, or if they're, like if that's the path to Ozempic versus Wegovy, is the idea that then they will be using Ozempic off label for weight management, and that would be approved before they would be then approved for Wegovy at the 2.4?
Right, so yes, that's true.
Okay.
This is Tim. Did I miss it? Is there a lifestyle education requirement prior to prescribing?
Yeah, in number 18, we do ask that they've tried some kind of program for at least 3 months in the previous 6 months time frame. Unfortunately, we don't have a standardized.
Okay, so as long as the provider can send a documentation that they've been a part of Weight Watchers, or they've seen a dietitian 3 times or something like that, that's what you're looking for.
Yeah, just some kind of attestation that they've tried something.
Right, and the provider can just attest. We're not asking them to send, chart notes from the dietitian or anything, correct?
That's correct. Yeah, just because of access,
Right.
we
I
didn't.
know.
Yeah, we didn't want to be too specific.
No, I agree with that.
Those are great questions, though. I really appreciate it. Are there any other questions, or I can move on to the recommendations? So then the recommendation would just be to implement the PEG criteria for semaglutide or Wegovy that we just went over. And then, yeah, if there are any other questions, I think we have public comment on this topic as well.
That's correct, we do. So if there are no questions, let's entertain that, and then we'll still have room for more questions from the committee before we move to take a vote. So Crystal Hartman with the Obesity Action Coalition, are you able to unmute your line?
Yes, can you hear me okay?
Can hear you loud and clear. I'm
Okay,
bringing up a timer.
perfect.
Yeah, so you have 3 minutes. Crystal is with the Obesity Action Coalition. Didn't disclose that there's any, they are an advocacy organization. They do receive some, I think, funding from pharmaceutical entities, but was not requested to be here on behalf of a pharmaceutical entity. And with that, the floor is yours.
Thank you so much. Yes, I am a patient that is living with the chronic disease of obesity for almost 30 years now, since I was in my teens. I'm an Oregonian born and raised, and I am currently actually on Oregon Medicaid. So I'm going to put my comments kind of into 2 separate sections today. The first one, I will address the statement that was released today about the lack of adult coverage, and the second will be about the cardiovascular indication. But I wanted to say that first, given the notification just today that we are not going to be covering medications for adults living with the chronic disease of obesity, I am extremely disappointed in the exclusion of adults on Medicaid for access to obesity medications. Due to losing my job in a layoff, I'm a Medicaid patient currently. And I believe that, the lack of coverage of these medications means that we as a state are not keeping up with the science behind GLP-1s for obesity and other comorbid conditions. And we're seeing more and more benefit for multiple diseases as the reason we are here today to talk about this further indication. So I believe this is a very short-sighted decision, and I don't think that it is fair to blame it on cost, because we all know that the state will not pay anywhere near the pharmacy cash price for these GLP-1 drugs. So as a native Oregonian adult on state Medicaid right now, this decision makes me very angry that my state is not listening to its people and fulfilling the, vast medical need that treating adult obesity really entails. So I wanted to make sure to get that point across today. The second point I want to make is really about this cardiovascular disease indication. Cardiovascular disease runs in my family. It runs in my husband's family. It is starting way younger due to obesity. And for example, my husband had a heart attack at age 44, and I and our 3 kids almost lost him. He is also currently on Oregon Medicaid. And this means by age, he wouldn't qualify for a GLP-1 given these new PA requirements because of his age, even though he has cardiovascular disease and has one of the events that necessary for that. So I just urge the committee to really look at the science behind GLP-1s for obesity. I understand that probably following the actual study parameters is easier, but you should also be looking at the label, the FDA approved label for these medications, and considering them for a broader population as well. We all know that obesity is chronic, it is lifelong. We are finding more and more disease states that GLP-1s are positively impacting. And as a state, we need to support coverage of these for our people. Thank you.
Thank you, Crystal. Are there questions from the committee for Crystal? I appreciate your advocacy and your comments, and yeah, those are part of the recording and will be carried forward. So thank you very much, Crystal. Jamie Sweeney, Jordana Sweeney, are you able to unmute your line?
Yes, I am. Thank you.
Great. So for the committee, she's an employee. Actually, the question was if you're an employee of a pharmaceutical manufacturer. You responded that you are, that you work intermittently as a contracted speaker for Novo Nordisk, and you're in their obesity specialist department. And so with that, the floor is yours.
Thank you. So my name is Jamie Sweeney, and I'm a family nurse practitioner with the OHSU's Bariatric and Obesity Management Program. I have 16 years of experience in family medicine and 8 in obesity management. I want to express, first of all, my sincere appreciation to this committee for making Oregon a leader among the states by looking at ways to improve access to obesity care, including potentially medication coverage. This work can only bring hope to millions of Oregonians that access to equitable health care is important and a priority in this state. However, I know today's discussion is not about obesity per se, but actually focused on cardiovascular disease. So let me go there. I cannot recommend strongly enough that this committee approve coverage of Wegovy for secondary prevention of cardiovascular disease for all adults with overweight and obesity per the FDA's new indication. With regards to the prior authorization process, because of time constraints, I will limit my recommendations to my 2 most pressing. Number 1 is the criteria number 15, coverage limited to age 45 and older for medical appropriateness. I want you to think about someone like Crystal's husband, who is unfortunate enough to have a heart attack before the age of 45. Do we want to delay treatment to prevent their next cardiovascular event? I don't think so. I think that's unintended. So I recommend changing the criteria from age 45 to age 18 and over, which would then again be in alignment with the FDA's indication for use. My second recommendation is to actually remove entirely the prior authorization criteria number 18 and the renewal criteria number 5. We are talking about this for cardiovascular prevention and not for obesity management. These are the requirements for patients to undergo 3 months of weight loss treatment prior to starting medicine, and the requirement to lose or maintain a BMI reduction of 5% to continue medicine. These are not based in evidence, nor are they the standard of care we use for treating any other chronic disease. The evidence is the SELECT trial. This study was designed as a cardiovascular outcome study and not a weight loss study. Weight loss and lifestyle changes were not required, And the risk reduction was seen independently of the weight loss, meaning that someone who lost 5% of their weight or less than 5%, and those who lost more than 5%, both had the same cardiovascular risk reduction. Weight was not a factor. Next, the standards of care for chronic disease, regardless of BMI, weight loss is not required before starting any medications for diseases such as diabetes, hypertension, or hyperlipidemia, no matter the expense of the medicine. Why is this any different? Making a patient prove that they're worthy of treatment by putting this criteria in as a gatekeeping method creates a significant barrier to care and may unfortunately be what I am absolutely sure is unintended, unconscious weight bias. Therefore, I recommend removing both of those criteria. I have a ton more to say on this topic, but I realize that my time is running out and I want to be respectful of those here. And I really appreciate the committee's time and being able to address you.
Thank you, Jamie. I appreciate it. For the committee, any questions for Jamie?
This is Eric Onishi. I just wanted to appreciate all their comment.
Thank you.
Thank you, Dr. Nishi. All right. Thank you again, Jamie. Josh Akers, Eli Lilly, are you able to unmute your line?
I am here. Can you hear me?
Can hear you loud and clear, Josh, and the floor is yours.
All right, great. Thank you for having me today. My name is Josh Akers, and I'm an outcomes liaison with Eli Lilly. I just wanted to go on record today that I am just here to answer any questions regarding any cardiovascular outcomes trials related to any of the Lilly assets. If there are any questions, please ask me. Otherwise, I will yield my time back to the committee.
I have a question. Were there any, did the study check for lipoprotein A, patient with a lipoprotein A?
So, Dr. Onishi, Josh is with Eli Lilly, not with the manufacturer of
okay,
Wegovy, but no, it's a good question. But we do have a representative. I mean, unless Josh, you're willing to jump in there and take a stab at the study that wasn't performed by Eli Lilly. I don't think you are.
I am not going to do that.
I don't blame you.
Sorry.
No, that's
No
a great
worries.
question. All right. Thank you for your time, Josh. So we do have Kat Kachatourian, medical liaison with Novo Nordisk. Kat, are you able to unmute your line?
I am, Roger. Are you able to hear me?
Hear you loud and clear, and the floor is yours, and you even have a question that was teed up for you. So.
Yes. In response to that question, lipoprotein A was not monitored specifically in the SELECT patient trial. There are ongoing subgroup analyses and post hoc analyses. So that is something I can take back to my company and determine if that is a part of our post hoc analysis plan, but it is not something I'm aware of at this time.
Great. Thank you. So you have 3 minutes now, and then we'll leave the committee some time if they have any questions or answers with you after that's concluded.
Great. Thank you so much. So hi, my name is Kat Kachatourian, and I'm a pharmacist and represent the Novo Nordisk Medical Affairs team. I want to thank you for opening up the conversation around CV risk reduction and add comments regarding the proposed criteria for use of anti-obesity medications in Oregon for patients with cardiovascular disease. Regarding the proposed approval criteria, for criteria number 8, I'd like to remind the committee that the updated label for semaglutide 2.4 milligrams does not include BMI cutoffs and instead contains the language as Wegovy is indicated for patients with overweight and the presence of at least one weight-related comorbidity. Aligned with guidelines, this would include a BMI of 25 or more with a comorbidity. For criteria numbers 15 through 17, while these criteria are aligned with the CV Outcomes Trial SELECT inclusion criteria that was previously presented by OHA, it is more restrictive than the FDA-approved indications for semaglutide 2.4 milligrams as of March 8th, 2024, as other commenters have noted. The cardiovascular indication was granted as a result of the SELECT trial. And as a reminder to the committee, SELECT patients had underlying 82% had coronary heart disease, 82% with hypertension, and 24% with heart failure. This also included elevated cholesterol, blood pressure, etc. As noted in the materials, select trial patients treated with Wegovy did experience the reduced relative risk of MACE by 20% compared to placebo when added on top of other standard of care CV regimens. And then for criteria number 19, as the committee has already acknowledged, Ozempic 2 milligrams weekly is FDA approved for the treatment of patients with diabetes. And while Ozempic does carry a cardiovascular risk reduction indication, it is not FDA approved for use in patients without diabetes. As a reminder to the committee, the cardiovascular risk reduction for Ozempic was evaluated in SUSTAIN 6. In this trial, 3,200 patients with inadequately controlled type 2 diabetes and ASCVD were randomized to receive Ozempic or placebo, along with standard of care treatments. Additionally, the most common side effects of semaglutide are GI in nature, include nausea, diarrhea, vomiting, constipation, among other effects listed in the package insert. No new safety signals were detected in the SELECT trial. I'm happy to send the committee additional information, and I'm happy to also answer any questions you may have. Thank you for your time today.
Thank you very much, Kat. Open it up to the committee. Do you have any questions for Kat? Dr. Onishi, would your question adequately answered?
Yes, I guess. Thank you.
To be continued, you bet. All right. Thank you for your time, Kat. All right. I'm going to turn it back over to to Kathy.
Great, thanks, Roger. Yeah, so the recommendation would just be to approve the criteria, the updated criteria for weight management medications. And
I make a motion for approval of the recommendations as stated.
Second.
All those in favor?
Aye.
Aye.
So sorry, I guess my question is like age-wise and everything, or? is
That's
that-
correct. That's correct, Erika.
Did you want to make a motion to change the age, Dr. Onishi?
Well, I guess as a primary care, I appreciate all the people who came and talked to us, and that's what I see in the clinic. All I see is obesity is really, really killing Americans, and I really emphasize that I really want to Medicaid to cover these medications. I know this is for the CVA, but my suggestion is really decrease this threshold down and cover for obesity.
We have a motion on the floor. Dr. Onishi, I made that, and with the strict, this is kind of a package. This package was based on the study. The original study for which the FDA was approved, and then the FDA is well known for being squishy on post-approval and other, but we've got the study up before us. We've used the criteria for it. We recognize it's restrictive. We also recognize that we wish that we could expand for obesity, but I would say we're looking at cardiovascular risk in the SELECT trial. And what we can do is we can ask the representatives of the pharmaceutical companies to price their drugs similar to every other single country in the world. And we would be having a very different discussion today at the Oregon P&T committee. So those aside, my motion still stands approved. And second, Mr. Chairman or Ms. Chairman person.
Perfect. Thank you. All right, so we have a motion and a second. So let's take the vote and go from there. So all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you all. Motion passes.
And so now, Dr. O'Neill, independently, we've cleared that motion. So you can make the motion that you wish to amend this criteria and change the age and see if that gets any traction.
Well, at least can we do that?
Yeah, you can make a motion, and then if someone seconds it, we would move on to a vote. So, but that's totally up to you.
Well, I would say I actually will think it will be appropriate to bring it down to 18. I do.
Okay.
I would love to second that.
Okay. All right. So we have a motion and a second to amend the PA criteria that we just approved to remove the age restriction or change the age restriction from 45. And then Roger, do we change it to 18 or do we change it to 21 because of EPSDT?
I think in that case, it would be removing the question altogether.
Just remove the question. Okay, perfect. All right. So the motion has to remove 15 altogether has been made and seconded. All those in favor? Opposed?
Aye.
Nay.
Yeah.
Nay.
Nay.
Right. Anyone abstaining? Okay, so I'm assuming that that Erica and I'm sorry, I didn't see who seconded, but
I thought it was Rico and Samara were
It
the
was.
motion and second. They didn't
Okay.
say aye, but then I heard no one else vote for that recommendation. The nays were the majority.
Yes, perfect. All right, thank you.
All right, thanks for the discussion.
But can we ask why nay or no? That's not the discussion.
No, we're not going to get into
No.
Okay.
defending or doing that. So I
Okay.
appreciate it. Yeah,
Thank you.
thank you. So appreciate the conversation, discussion. Next, we're going to move on to Pompe disease class update. In the packet can be found on page 166, and we'll turn it over to Dave Ingen.
Okay, thanks, Roger. Yeah, today we'll review the class of lysosomal storage disorders, specifically those agents used in the treatment of Pompe disease. Next slide, please. Yeah, so this review was prompted by the release of a new agent, cipaglucosidase alpha. It's a new recombinant human acid alpha glucosidase, abbreviated GAA. That's prescribed in combination with miglustat. We'll evaluate the evidence for its safety and efficacy in the treatment of Pompe disease. So just a high-level refresher, Pompe disease is a rare degenerative disease. Patients lack an enzyme called lysosomal GAA that leads to buildup of glycogen in muscle tissue and other tissues and motor neurons, which may hinder mobility, respiratory function, and have variable impacts on quality of life. And that's often correlated with the amount of GAA activity. There's two forms of Pompe, one that could hit infants usually before 12 months of age, and there's also a more common late onset form. Therapy is usually multidisciplinary and largely supportive in nature, but it may involve enzyme replacement therapy, depending on the type of Pompe, disease severity and symptoms, and rate of progression. So the next slide, please. And here are the enzyme replacement therapies that are available. In past meetings, we've looked at L-glucosidase and avalglucosidase alpha. We'll review a third agent, cipaglucosidase alpha, here in a minute. And yeah, looking at some common outcomes in clinical trials includes measures of functional endurance, such as the 6-minute walk distance test. There's also measures of respiratory function, such as forced expiratory volume. There are minimum clinical important differences reported in the literature for other disease states, and sometimes those are used to establish whether, in this case, therapy is providing a benefit. Now we can look at the drug itself on the next slide. So cipaglucosidase is given in combination with miglustat, and that's for stability. And it's FDA approved for the treatment of adult patients with LOPD, so that's a late onset Pompe disease, weighing 40 kilograms or more, and who are not improving on their current enzyme replacement therapy. The main trial, PROPEL, compared cipaglucosidase alpha plus miglustat to alglucosidase alpha plus placebo. And it was a phase 3 randomized trial in 123 patients over 52 weeks. Generally, baseline characteristics were similar, included mostly middle-aged ambulatory patients around 46 years of age. The primary outcome studied was a change in 6-minute walk distance. And as a secondary outcome, they assessed the change in sitting percent predicted FVC. Both were measured at 52 weeks. Well, it turns out the mean change in the 6-minute walk distance of 14 meters, roughly that, did not demonstrate a statistically significant difference compared to alglucosidase, but there was a slight difference in percent predicted FVC of 2.3% that favored cipaglucosidase. As far as the safety, there were generally similar adverse reactions between the two treatments. However, in the trial, alglucosidase treated patients reported more issues of abdominal pain and nausea during the trial. There were some trial limitations, and one of them, the primary outcome measure, it failed to demonstrate a statistical difference. So that one was glaring. The active comparator used in the trial was not an FDA-approved formulation. And we're lacking long-term efficacy and safety data. And there appeared to be an underrepresentation of non-white individuals. If we look here at the PA criteria, we've added cipaglucosidase alpha to the table and have the appropriate dosing and indications in there. And so we also updated the criteria with a few questions. And if you go to the next page, now, it's first we wanted to remove question number 3, and I don't think that's change quite made into the slides, but it's in your packet. And what that question says is there documentation that the patient is switching enzyme replacement therapy or ERT agents due to lack of benefit with prior therapy? And since cipaglucosidase actually has this indication in the label, we decided we should strike that. So that's not on this slide, but it's in your packet, and we'd like to remove that question. But then you can see here on the slide itself, number 12, it asks if the agents are being prescribed for Pompe. And then number 13 ensures that all the agents will be appropriately used in combination where appropriate. So that's pretty much it for the changes in the criteria. It's just basically incorporating the new drug into the existing criteria. So yeah, with that, the recommendations were going to be to implement prior authorization criteria for cipaglucosidase alpha and miglustat combination therapy, and then evaluate costs in executive session. I don't believe we have public comment, but I'd be happy to take any questions.
That's correct. We don't have anybody. Questions for Dave?
Motion to approve.
Thank you, Pat.
Do we have a second?
Second.
Thank you.
Second.
All right, all those in favor?
Aye.
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 Opposed?
Aye.
Oops, opposed? Abstain? All right, thank you.
Thank you.
All right, we are scheduled for a break at this time, but instead of 15 minutes, if it's okay with the committee, let's take a 10-minute break, and then we'll reconvene and continue on with the agenda.
Sounds good.
I will put my timer on, and we'll see you back here in 10 minutes. Thank you. Okay, that was a quick 10 minutes, but I hope everybody had a moment to get refreshed. We still have a fair bit of agenda to get through. So with that, we're going to forge on if you're following along in the packet or on page 188, and we'll turn it over to Megan Herring for the gabapentinoids.
Okay, thank you, Roger. The purpose of this review is to evaluate the evidence for compendia supported, funded, and non-neuropathic off-label uses for gabapentin and pregabalin. Some background and context for this review. A previous drug utilization evaluation and indication review that we did found that less than half of the OHP members with fee-for-service claims for pregabalin had an FDA-approved diagnosis in their medical claims. And the most common diagnoses identified in that review for members with claims of pregabalin were diabetic neuropathy or diabetes, other neuropathies and nerve injury, and fibromyalgia. And a diagnosis of generalized anxiety disorder was present in the medical claims for 14% of members who had a claim for pregabalin. The Mental Health Clinical Advisory Group's treatment algorithm for generalized anxiety disorder includes pregabalin as first-line agent treatment for patients with generalized anxiety disorder and recommends the following for consideration. Recommendation 1 was to remove the PA criteria for pregabalin, or recommendation 2 was to add anxiety to table 1 for pregabalin and do not require prior treatment or intolerance to gabapentin for use. Next slide. And so our current policy is there is a prior authorization required for pregabalin. The goal of this is to limit use to FDA approved and OHP funded indications. It does require documentation of a trial and failure, contraindication, or intolerance to gabapentin first. And lastly, gabapentin is preferred and available without prior authorization. So here are some of the FDA approved and off-label indications for both pregabalin and gabapentin. You can see kind of the top row that the FDA approved indications for each of them, followed by the compendia supported off-label indications. The unfunded off-label indications, including restless leg syndrome and fibromyalgia, and then the neuropathic pain off-label uses. For the purpose of this clinical review, off-label uses with only category C compendia evidence, which is based on data from expert opinion or consensus case reports or case series, were excluded. Unfunded conditions were excluded, including fibromyalgia and restless leg syndrome. Since postoperative pain studies focus on short-term treatment in the immediate post-op period, usually prior to hospital discharge, and outcomes are usually 24 to 78 hours post-op. This off-label use was excluded from the review. And lastly, treatment for neuropathic pain has been reviewed separately by the P&T committee. Next slide. These are the off-label uses identified with insufficient evidence, again, based solely on expert opinion or consensus, post-hoc analyses, case reports, or case series. For pregabalin, this includes familial dysautonomia, cancer-associated neuropathy, refractory cough, panic disorder, and vasomotor symptoms associated with menopause. And for gabapentin, this includes trigeminal neuralgia, generalized anxiety disorder, refractory cough, panic disorder, and social anxiety disorder. I will point out that you can see that general anxiety disorder is only category C evidence for gabapentin. Next slide. Based on a literature search, there is very low quality of evidence supporting pregabalin for obsessive compulsive disorder based on only one small poor quality study, and very low quality of evidence supporting pregabalin for ureteral stent related symptoms based on 2 small open label trials that showed some benefit only when pregabalin was used in combination with an anticholinergic medication. Next slide. For generalized anxiety disorder, there were 2 systematic reviews and 8 randomized controlled trials identified and included. Overall, there was moderate quality of evidence that pregabalin at doses of 300 to 600 milligrams per day decreases anxiety symptoms compared to placebo, as measured by the Hamilton Anxiety Rating Scale, or the HAM-A. This is based on studies of short duration, usually 4 to 8 weeks, with high risk of attrition bias. Additionally, studies did demonstrate a medium effect size that is similar to venlafaxine and other studied SSRIs and SNRIs in generalized anxiety disorder. There is more limited evidence that studies pregabalin specifically as adjunct to SSRIs and SNRIs. There is low quality of evidence from one 8-week study that shows pregabalin modestly decreased anxiety symptoms compared to placebo when used as adjunctive treatment in patients who did not adequately respond to an initial 8-week trial to an SSRI or an SNRI. And so in this study, over the 8-week treatment period, patients receiving add-on pregabalin had an average anxiety score that was 1.2 points lower on the HAM-A compared to that baseline therapy alone. Lastly, there was insufficient data evaluating the long-term efficacy or safety of pregabalin in the treatment of generalized anxiety disorder, and insufficient in data in patients with comorbid substance use or other mental health disorders, as these were often exclusion criteria for these studies. There are clinical guidelines from the National Institute for Health and Care Excellence that were updated in 2020. And they recommend that if a person cannot tolerate SSRIs or SNRIs, to consider offering pregabalin. They also include the caveats that pregabalin is associated with increased risk of abuse and dependence, and so evaluate patients carefully for a history of drug abuse prior to, and that also patients should continue to use effective contraception during treatment and avoid use in pregnancy unless clearly necessary, due to data suggesting that pregabalin may slightly increase the risk of congenital malformations after exposure in the first trimester. For other off-label uses that were included in this review for uremic pruritus, there were 2 systematic reviews that were identified. There is moderate quality of evidence that gabapentin improves uremic pruritus in patients with chronic kidney disease stages 4 and 5. This was measured by a 10-centimeter visual analog scale. So compared to placebo, it was about 4.95 centimeters lower. And there's low quality of evidence that gabapentin may modestly reduce symptoms of uremic itch compared to antihistamines. Furthermore, so most of the evidence in these systematic reviews was for gabapentin. There was one small study that showed no significant difference in itch reduction between gabapentin and pregabalin. And then lastly, the optimal dose remains unknown for this, and dosing interval and side effects need to be carefully considered in patients with chronic kidney disease because of the renal clearance of these medications. Next slide. For vasomotor symptoms associated with menopause, there was one systematic review and 2 randomized controlled trial that were evaluating gabapentin. There was insufficient evidence to evaluate pregabalin, and there was low quality of evidence that gabapentin modestly reduces frequency of hot flashes associated with menopause compared to placebo at 12 weeks. With a mean difference of 2.77, with no difference in duration or severity score. The trials identified did not consistently meet the minimum clinically important difference for vasomotor symptoms. Lastly, there is evidence of racial and ethnic differences in vasomotor symptoms. However, studies included mostly white participants, and there is insufficient evidence in other racial groups. For alcohol dependence, there was 4 systematic reviews identified, and I think 3 randomized controlled trials. The majority of the evidence is in gabapentin. There is low quality of evidence of no significant difference in improved alcohol abstinence rates with gabapentin, or benefit on relapse to heavy drinking. There is low quality of evidence that gabapentin may reduce the percent of heavy drinking days, decrease alcohol consumption, and decrease acute alcohol withdrawal symptoms. Guidelines from the U.S. Department of Veterans Affairs recommend gabapentin as a second-line option for alcohol use disorder with a weak recommendation, and as an option for alcohol withdrawal when the risks of benzodiazepines outweigh the benefits. So for all of the off-label uses of gabapentin and pregabalin, there is a consistent trend toward higher rates of discontinuations due to adverse events compared to placebo, the most common adverse events being dizziness, somnolence, headache, and sedation. However, rates of serious adverse effects are low. For most off-label uses, there is heterogeneity in the dosing among studies. Inconsistent dose response seen, high rates of attrition, and little guidance on optimal dose. So in conclusion, pregabalin may be beneficial in generalized anxiety disorder for those who cannot tolerate or have failed first-line therapy with a SSRI or SNRI. Common side effects, risk of misuse and abuse, and FDA warnings for
Megan, you just got on mute. Hold on 1 second, please.
Sorry, somebody muted me, but
don't take it personal. Hold on, just back up just a little bit, please.
What was that?
If you can just back up a little bit because you're muted for just maybe 5 seconds, but I wanted to not miss anything.
Okay. So common side effects, risk of use and abuse, and FDA warnings for respiratory depression when used in combination with opioids needs to be considered prior to use. And so our recommended policy changes are to modify prior authorization criteria to allow use of pregabalin for generalized anxiety disorder without a prior trial of gabapentin. Next slide. So this is the current criteria, just asking if for the diagnosis. And then number 5 is the request for an OHP funded diagnosis. If yes, next slide. Then asks for documentation that the condition is of sufficient severity that it impacts the patient's health. If yes, it asks that if the request is for an FDA approved or evidence supported diagnosis, and it refers to table 1. And so the recommendation is to add generalized anxiety disorder to table 1 to allow use, and then approve without requiring step 9, which is that the patient has tried gabapentin prior to pregabalin. And with that, I can take any questions.
Yeah, we don't have anybody that signed up for public comment, so thank you, Megan. Good job. Any questions from the committee for Megan? All right.
Well, this is Russ. I make a motion to approve because I think this is a good idea.
Do we have a second?
Thank you, Russ.
Oh, Pat. All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you all.
All right. Next, we'll turn to page 210 in the packet, and we have the gene therapy for sickle cell disease and beta thalassemia. Get some new drug evaluations that Sarah Fletcher is going to present.
Thanks, Roger. Yes, we're going to talk about the new sickle cell and transfusion-dependent beta thalassemia gene therapies. If you go to the next slide. Right now, these the two gene therapies that we're going to go through, they're the first ones for sickle cell disease. There's two of them, and then one of them is also approved for transfusion-dependent beta thalassemia. There was a previously approved gene therapy for that. It's called Zynteglo, and that one was reviewed by the committee in October of 2023. If you go to the next slide. So one of the two drugs that I wanted to go through today, both of them require myeloablation, but they have different mechanisms. This one is a CRISPR-based or edited gene therapy. It's approved for sickle cell disease and those with recurrent vaso-occlusive crises and transfusion-dependent beta thalassemia, both of them in age 12 and older. And in the DERM packet, the information used for that was based off of clinicaltrials.gov, the PI and FDA reviews as I could find it. They were published right before and right after final posting. And so that wasn't incorporated into the final document that you see, but I've looked at it and it's pretty similar. It was going over similar data. If you move to the next slide. Lovo-cel is the other gene therapy that we're going to look at today, and it is a stem cell based therapy that involves an insertion with a lentivirus vector. So it's a little bit more similar to some of the other gene therapies that we've reviewed in the past. It has one indication, and that's for sickle cell disease with vaso-occlusive events in those 12 and older. I wrote events in one and crises in the other. That's based off of just the FDA and how they were labeled in their own trials. The actual crises and events were pretty similar. There was most overlap, but just a little bit of difference, but it's probably not a clinically significant difference as far as calling it a vaso-occlusive event versus vaso-occlusive crisis. I just wanted to note why I had different terminology there. If you go to the next slide, there's 3 studies I wanted to go through quickly. One of them is exa-cel for sickle cell disease. This was the CLIMB SCD study. It's an open label single arm multi-center trial because this involves myeloablation. There's no placebo control. And for the June 2023 data lock, the safety group was 44 patients. Those are the ones who'd received the therapy. And then the efficacy group was 31. And those are the ones who had been followed long enough to be able to be assessed for the primary endpoint. As far as demographics, patients had a median age of 21. They were 45% female and 87% Black, which is in line with how sickle cell disease does predominantly affect people of African origin. The average number of vaso-occlusive crises in patients entering this were 3.5 per year, and hospitalizations of about 2 to 2.5 a year. You can see the inclusion criteria were those aged 12 to 35. They had severe VOCs in each of the 2 years prior to enrollment. These were acute pain, acute chest, priapism, and splenic sequestration. And they did include or allow inclusion of all genotypes, but the first one includes about 90% of those who were enrolled. For exclusion criteria, advanced liver disease, baseline GFRs that were reduced, an elevated level of fetal hemoglobin, and then HIV, HBV, or HCV positive, so seropositivity. They looked at core antigens and PCRs for the hepatitis positivity. And then a transcranial Doppler was also looked at to assess for any kind of history of cerebral disease. The duration or the median duration for the data lock that I was able to see was a median of 26 months. And the primary outcome was vaso-occlusive free for 12 months. And that was within a 24-month period post gene therapy. It was a time to event metric, which is a little bit different than what we'll see with the other study. The FDA did note that because it was a time to event within a larger period of time, it increased the ability to meet the primary outcome by about 2 to 3-fold. But the response rate was 29 of the 31 patients at that point, and that was 93.5%. And then the secondary outcome was hospital-free for 12 months within that larger time frame, and that was 100%. There was one patient that wasn't able to be assessed for that. That's why the number is different for the overall 30 versus 31. So if you go to the next slide, This one is exa-cel for beta thalassemia, so a different indication, but the same drug. And it's going to be pretty similar for the first few lines. It's open label, single arm, no comparator, a safety group of about 52 versus efficacy of 35. Similar ages and genders, but it was more predominantly Asian because that is who is more predominantly affected by beta thalassemia. The annual red blood cell transfusion rate was about 17 per year. And this beta naught genotype made up more than half of those enrolled. And I just want to call that out a little bit. Zynteglo, the other drug that is approved for this indication, 9 of their patients, which was about a quarter to a third, had this genotype, and they had a much lower response rate to the gene therapy and then were excluded from the subsequent studies. So it's good to see that this more severe genotype is heavily represented in this study. The inclusion criteria age was similar. They included multiple thalassemia subtypes, and they defined transfusion dependence as more than 100 mLs per kilo per year or 10 units per year in multiple years. Exclusion criteria, again, advanced liver disease, iron overload, and then some of the alpha thalassemia deletions, as well as HIV, hepatitis B and C. And then the duration was also similar, about 23 months. This one had a primary outcome of transfusion independence for 12 months, 12 consecutive months within that larger window, and it was met by 91% of the patients. And then if we go to the last study on the next slide, this is lovo-cel for sickle cell disease. So the other medication, but the first indication. So lovo-cel for sickle cell, both of them are approved for sickle cell. And this was, again, an open label, single arm, multi-center study of about 30 patients. Had similar ages, 38% female, 97% Black, so a little bit higher in this one. This study did allow patients who'd had a silent vasculopathy, so it was found incidentally later, and 100% were that genotype that was also heavily represented in the exa-cel study. Inclusion criteria, they did allow patients that were a little bit older. I think 45 was the oldest patient in the study, and at least 4 VOEs in the 2 years before enrollment, which is similar to the last one of at least 2 in each of the 2 years of prior enrollment. And then some of the major exclusion, which the study document or the final documents that are posted have more exclusion criteria, but again includes advanced liver disease, certain infections, and then the severe cerebral vasculopathies. The duration is ongoing, and this one had a primary outcome of a vaso-occlusive event free within months 6 to 18 post-infusion, so it's a little bit more restrictive. So the response rate for that was 88%, and then severe vaso-occlusive free for that 6 to 18 months. So things like hospitalizations, and that was 94%. And they defined VOEs as chest pain, acute chest, acute pain, acute hepatic sequestration. So that was a little bit different than the last one, and acute splenic sequestration. So you go to the next slide. Obviously, these have some limitations just by nature of how they're having to be studied. So they're ongoing. We do have some of the publications now, but overall, we're still waiting on some of the data. They're open label, single arm, which has certain biases associated with it. And as gene therapies are pretty new, we don't know the durability of response. We're learning as we get more data along the way. And then there were some slight differences in the endpoints and the inclusion-exclusion criteria between these different medications. So the next slide is safety. So exa-cel, which is the one with 2 indications, 45% of patients had a severe adverse event, but most of that was after myeloablation. There was 1 death, but it was not presumed to be associated with the therapy. And you can see the most common adverse events were ones that you associate with myeloablation. And then the FDA did note that there was delayed platelet engraftment, and that was compared to patients who'd received a stem cell transplant with an HLA match donor in the past. So when they compared those time periods, they said that this was a bit delayed. And then for beta thalassemia, similar 33% adverse event rate after myeloablation, and also some of the more common side effects are also very similar. If you go to the next slide, lovo-cel for sickle cell disease, it actually has a boxed warning, and that is for AML in 2 of the patients in some of the earlier studies where they were using a different transplant procedure and different processing procedure, as well as 1 case of MDS in a patient that has some of the alpha thalassemia traits. So it has a boxed warning for malignancy. About 73% of patients did experience a severe adverse event. Similar to the other ones, it was after the myeloablation with some of the similar most common side effects. And then delayed platelet engraftment was noted here as well. The package insert does have a limitation of use, which is what that last bullet is, in patients who have alpha thalassemia traits. And there were some exclusions for some patients with certain gene deletions. So if you go to the next slide, we're going to move over to the PA because there are two new PAs and they're in the packet on page 227. Give Sarah a second as she switches. Okay, so both of these drugs, I've prepared a PA for restricting them to their clinical approval. And so they're fairly simplistic because at the time I didn't have all of the inclusion and exclusion criteria and all of the data, but we're going to look through on exa-cel. Is it the indication? What is the approved indication? Is there documentation of not having received another gene therapy or stem cell transplant for sickle cell disease or anything else? Is it being ordered by or with a hematologist? And then we have a divergence based off of the two different indications. So confirmed beta thalassemia, you would go to question 6. I've defined the confirmed beta thalassemia as it was defined in Zynteglo, which had the same ml per kilo per year, but theirs was 8 transfusions. I wanted to keep them similar because they're for the same indication. And if the patient does not have beta thalassemia, then you would go to question 7, which is assessing the number of vaso-occlusive crises. And I've included all of the examples from the 2 different studies as what some examples of vaso-occlusive crises might be. And we have an age restriction, as well as the advanced liver disease, documentation of HIV, hepatitis B or hepatitis C. Those would be active infections, so acute or a chronic infection that's not yet cleared. And then because there are so many health-associated side effects that come with myeloablation, and the exclusion criteria are so extensive, we have a general attestation of health, which is how we did Zynteglo as well, to make sure a patient would be able to tolerate myeloablation without making each one a different line item. You go to the next slide. Because of, again, of myeloablation, there is obvious risks with childbearing potential or future childbearing potential. And so I have a few questions related to that as far as if it's been discussed and future fertility preservation being discussed. There's some federal programs that are currently being, I think, they're not approved yet, but I think kind of looking at this problem or looking at making sure that there's a solution for this problem so that a patient who gets this as a young child doesn't lose their ability to fertility later. If we go to the next page or a little bit lower, we've got the lovo-cel PA, which is similar, but I've added a few more safety things because of those black box warnings, where we have the approved indication, restriction to a hematologist, the same definition of VOCs, the age restriction, liver disease, and then number 8 is those alpha thalassemia traits that have been associated with MDS or excluded. And so there's that limitation of use in the PI. Number 9 is the same as is number 10. And then because this one is insertional based gene therapy, there's a risk of oncologic insertion later on that requires certain monitoring. And so that's what number 11, or where number 11 comes from. There's a requirement to have monitoring every 6 months. And then the 12, 13, 14, 15 are the same as what we see in exa-cel. So are there any questions that I can answer related to this from the committee before we go to public comment?
Good job, Sarah. Questions for Sarah? We can always come back to those after we entertain public comment. We have 2 representatives. First, I have Chad Duncan, Field Health Outcomes and Outcomes Researcher for Vertex, the manufacturer of Casgevy. Chad, are you able to unmute your line?
Yes, can you hear me?
Can hear you loud and clear. And
Great.
with that, the floor is yours.
Thank you. Sarah, a great review really of the class, and I don't need to really reread a script that we have about a lot of those things that you've just covered there. But I have one question or comment really about the criteria number 10. Is there documentation that the patient does not have HIV or active infections, either acute or chronic, of either Hep B or Hep C? In our label from the FDA, talking about that in section 8.8 of the label. It says Casgevy has not been studied in patients with HIV-1 or HIV-2 or HPV or HCV. Perform screening for those infections as well. And Casgevy should not be used in patients with active HIV-1, HIV-2, HPV, or HCV. The way I read the criteria currently is that if someone had any kind of infection of HIV, whether it was active or not active, they would not be able to receive Casgevy from the criteria. And so I would just, it's a question I really have is that the intent there, or do they need to not just have an active infection for HIV-1, HIV-2, HPV, or HCV?
Thanks for that question. My reasoning in that a patient who has HIV seropositivity, even if they have an undetectable viral load, it's just undetectable based off of our ability to detect it with the assays that we currently have. You continue to undergo treatment and you still have an active infection of HIV. It's a lifelong infection. And so that's why I worded it that way, to try to reduce that kind of question. For HCV and for hepatitis B and C, infections are acute or chronic or cleared. And so if a patient has cleared it, so they're not testing positive for viral loads and that kind of thing, then they would be eligible for it. But if they still had chronic disease or if they had an acute infection, they would not be able to receive it. Does that answer that question?
It does. What would happen if someone is HIV positive then and didn't even have, and their viral load is negligible?
Then they would not be able to receive it, and it would have to go to appeal through the medical director or through the appeals process. As of now, no one has been treated with a case of HIV, is my understanding.
Yeah, that's correct. I mean, from our clinical trial, and that's what the label says as well. But the FDA describes that as it should not be used in patients with active HIV-1, HIV-2, HPV, or HCV. It does seem to be a little bit of a difference from what you have written here. I think the second half of that sentence agrees with the label. The first part of it does not agree with the label.
Are you saying that the HIV does not agree, or the hepatitis does not agree?
The HIV does not agree.
From my clinical experience, if someone has an HIV infection, it is active, even if it is undetectable. Even though they can't transmit it generally, it's still considered an active infection. I know there are other practicing clinicians on the committee. If you have something else or another comment in relation to this.
Yeah, the committee.
I don't feel strongly on the semantics of active versus non, because we have a pathway to get the drug in the event that there is a medical review via an appeal. But I would be comfortable with adding the word active for active HIV, despite just the absence of any data.
But does that, to Sarah's point, that seems to me, if we say active, right, then there would have to be the opposite, which is inactive, and I don't think that exists. I agree with Sarah that when you have HIV, even if you're undetectable, you still have an active infection.
Agreed. So then, do we want it? You could use the word undetectable, or I think that or we could just have it be they need to seek an appeal. I think that would be reasonable too.
Yeah, I would lean towards that.
And for the committee, just to clarify, the other medication cannot be used in patients who are receiving HIV medications because of the viral lenti-vector mechanism. So it's a little bit different, just to make sure that we understand that they're a little bit different with these two drugs. And we're just talking about exa-cel right now, which is the CRISPR-based therapy.
And we do have one more. We have another speaker with Kaysen Bala, PharmD with Bluebird Bio, manufacturer of Lyfgenia. So Kaysen, are you able to unmute?
Yes. Can you hear me okay?
Hear you loud and clear, and the floor is yours.
Thank you so much. Thank you, Roger. Hello, good afternoon. I'm Kaysen Bala, pharmacist and medical liaison, Bluebird Bio. Really thank you for the opportunity to speak on Lyfgenia, one-time ex vivo hemopoietic cell-based gene therapy for sickle cell disease. Just want to thank Sarah and the clinical team, ensuring the PA criteria developed and presented really provides access to the most appropriate sickle cell patient population and also aligned to Lyfgenia clinical trial protocol. So I do understand, the committee has already had a chance to review all the materials and the clinical summary provided by the OSU College of Pharmacy. If you have any questions regarding, the FDA indication, limitation of use, the box label warning, or any of the clinical data, or even the very complex patient journey, I'm happy to address them. With respect to today's time, I just want to provide some updated information on the long-term follow-up data. As with any one-time therapy, durability is going to be our focus. At the December 2023 American Society of Hematology Conference, Bluebird Bio presented long-term data with both of our gene therapy programs, Zynteglo for the transfusion-dependent beta thalassemia and Lyfgenia for sickle cell. So with Zynteglo, which was approved back in August 2022, the follow-up period was up to 9 years. And the long-term follow-up did show that there was durability for transfusion independence and continued positive safety profile. But with today's focus is Lyfgenia, and the updated data cut was from February 2023, which includes 5 years of follow-up data, making it the longest studied gene therapy for sickle cell. So median follow-up time was 35.5 months, and the range was 0.3 to 61 months. And there were some unique patient characteristics, such as history of stroke and also chronic pain. So with the 34 patients evaluated, 94% experienced a complete resolution of all severe VOEs. And as Sarah mentioned, severe VOEs was patients having a VOE but requiring extended 24-hour hospital ER visits. But even in some patients that had some VOEs, they demonstrated clinical benefit with the reduction of VOEs for at least 50%, and there was significantly reduced hospital admissions and hospital days. The ASH presentation also highlighted some of the Lyfgenia data on sickle cell patients with a history of stroke. So with the clinical studies, there was a baseline demographics of 13% of patients with stroke. So all these patients were at least 18 years of age. And so at the 44 to 60-month follow-up, all 5 patients with the history of stroke remained transfusion independent and recurrent stroke. So I just have, that's all I have today with the time. If you have any questions, I'm here to answer them. Thank you.
Great, thank you, Kaysen. Any questions from the committee for Kaysen? All right, we turn your attention back to the recommendations in front of you.
All motion to approve.
Appreciate it, Pat.
Second.
All
Thank you,
those in
Eddie.
favor? Oh, wonderful. Sorry. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, motion carries. Thank you.
Okay. Next up are the antidepressant class update. That'll encompass a new drug evaluation, and we'll turn it back over to Kathy Centena. In the packet, it starts on page 232.
Great, thanks again, Roger. So today we'll be looking at the antidepressant class, as Roger mentioned. Purpose is to look at the literature and update it with any new evidence that's pertinent to our review, and then also to look at a new drug evaluation for Gepirone, which was approved for the treatment of depression in September of 2023. Included in this review is just a little bit of new literature. There wasn't extensive new guidelines or systematic reviews, as you'll see as we continue. But to give you a little bit of background, so the OHA Mental Health Clinical Advisory Group, as well as the American College of Physicians, recommend SSRIs, SNRIs, mirtazapine, or bupropion as reasonable first-line treatment options for adults with depression. So nothing new there. We did know that in major depressive disorder, about 2/3 of patients do have an inadequate response to therapy, and therefore about 1/3 of patients have treatment-resistant depression. As most of you know, antidepressants are carved out and designated as either preferred or part of a voluntary non-preferred drug list. And the specific antidepressant classes that we do have prior authorization criteria for are those that we feel need additional either safety precautions or guidance regarding medically appropriate use. So those are for things like tricyclics, zuranolone, brexanolone, and esketamine. As I mentioned, this review will be pretty brief, with just the inclusion of one randomized controlled trial, 2 FDA safety updates, and then of course our new drug review. So looking at the randomized controlled trial, this was actually a comparison between esketamine nasal spray versus quetiapine extended release. There's actually a flexible dosing regimen that was used, and then both of these products were used in conjunction with an SSRI or SNRI. The treatment phase lasted 8 weeks, and it was studied in adult patients with treatment-resistant depression. And the primary outcome was remission, defined as a MADRS score of 10 or less at week 8. You can see that esketamine was more effective than quetiapine, with remission rates of 27.1% compared to 17.6%, with a number needed to treat of 11. And these were in patients that mostly had severe depression and had failed 2 prior treatments. Moving on to the safety warnings, the first one's for esketamine, in which there's a new box warning of the risk of respiratory depression after administration, and that patients should be observed for at least 2 hours post-administration to ensure that they get the appropriate oversight. And then the next warning is related to SSRIs and SNRIs, that they might be associated with an increased risk for postpartum hemorrhage and loss of smell. Combination use of SNRIs and opioids may be associated with an increased risk for serotonin syndrome as well. And then in May of 2024, which was after the posting of this review, the combination dextromethorphan and bupropion product had updated labeling precautions, noting an association with Brugada pattern syndrome, as well as drug reaction with eosinophilia and systemic symptoms. So now moving on to the new drug review. This was approved, as I said, in September of 2023 for the treatment of major depressive disorder in adult patients. Gempirone is a azopyrone class of compounds, which is an analog of buspirone. So it's a little bit interesting in that it modulates serotonin activity by antagonism of the 5-HT1A receptors, which acutely decreases firing rate, but then over time actually increases the postsynaptic neurotransmission. It was evaluated in 2 studies that we're going to look at that were used for approval of the product, and they were 2 very similar studies in that they were both double-blind, placebo-controlled, randomized controlled trials, studying doses of Gempirone extended release 20 to 80 milligrams a day, with the most common dose being the higher dose in about 65% of patients in both the studies. These are both small studies, as you can see, around 200 patients and about mean age 38 to 40 years old. They both had baseline HAM-D scores that were, to be eligible, had to be over 20, which is considered moderate to severe depression. These studies lasted 8 weeks, with the primary outcome being the change in HAM-D17 total score at week 8. You can see there that the results were similar in both groups, with an improvement of around 2 points over placebo in both studies, which doesn't quite meet the minimal clinically important difference standard of around 3 to 7 points. You can also see that there were more responders with Gempirone, with a number needed to treat of 7 to 8 in both studies. So the limitations to these studies, as you can see, these are small studies, short trial durations. They also had some methodological challenges in that they lacked confidence intervals, as well as other details, leading to unclear risk of bias in a lot of domains. So it also, just as a side note, in the FDA review, this drug's been submitted for approval several times and was not able to obtain it, and some of the data suggests no lack of efficacy. So it did finally get approved, but the treatment effect is not substantial. Looking at the safety,
Kathy, you just cut out.
Oh.
All right, now you're back. It said looking at the safety, and then you stopped for a second there. So
Okay,
you.
well, good. Well, I won't reread the common safety or the most common adverse reactions. You guys can see those in the table there. I do want to mention this drug also has a black box warning for increased risk of suicidal thoughts and behaviors, as well as it should not be used in patients with a prolonged QT interval, as well as it has multiple drug interactions with CYP3A4 inhibitors, and should be dose adjusted with hepatic impairment. In the trials, this Gempirone was associated with discontinuations due to adverse events in around 7 to 10% compared to placebo, which is around 2%. So then moving on to the prior authorization criteria, going to talk about just the ones today that have changes associated with them. And then if there's questions, of course, we can look over the other ones as well. The first one is for tricyclic antidepressants. And you can see there that this is for use in children less than 12 years of age, and also to make sure there's a appropriate on-label use of these drugs. In the table, the only recommendation for change that I have is that the title be updated to include in children so that it's a little bit more clear to the PA desk. And I guess the one additional change in the heading, third row column over, add the word daily. Thank you for highlighting that. Just to clarify the dosing that we're talking about. And then on the next slide, if we look at number 3, so we're asking what diagnosis being treated, and then if the dose exceeds the maximum FDA approval dose in number 2, then we say yes, it does. Please go to number 3. And then here we ask, is there documentation that the prescriber is monitoring periodic levels to support the use of the prescribed dose? And this is recommended by the Mental Health Advisory Group. There's a pediatric psychiatrist that recommended that if TCAs are used in children above the maximum dose, that the blood levels be monitored. So that's the recommended change there. And then there's no additional changes to the TCA criteria. Again, just making sure it's per approved indication. And things like that. So we won't go into detail unless people have questions. And so the next slide talks about zuranolone, in which there's no new evidence and there's no changes. So we won't go over this unless there's questions. And the same for the next slide with brexanolone. So we'll go ahead and move on from that. There's no changes recommended. And then lastly, as ketamine, we do have just one change for clarification, and this relates actually to number 6 on the next slide, in which we're just asking if the patient's currently on a therapeutic dose of an antidepressant with a minimal effective dose being used, and then a link there to the different dosing regimens. And this just takes place of some the previous wording in which we had given a couple example antidepressants to use with esketamine, and there was a little confusion that those are the ones that had to be used. So we're just trying to streamline the wording there to make it more clear. That was the only change in that criteria. So again, we'll just keep moving on. So the recommendation is no changes to the fee-for-service PDL at this time, to maintain Gempirone as a voluntary non-prescribed medication on the PDL, and then to update both those criteria just to add clarity, the PCA criteria as well as esketamine. And then lastly, to evaluate cost in executive session. And I'd be happy to answer any questions or clarify anything.
The questions for Kathy. And we do have some public comments, so you can ask questions after as well. But see if there's any at this moment. All right, hearing none, we have Ronnie DePew, pharmacist with Axum Therapeutics, manufacturer of Avility. Are you able to unmute your line?
I am. Can you hear me?
Can hear you loud and clear, and the floor is yours.
Great. Thank you. Well, hello, I'm Ronnie DePew, Senior Director of Field Medical Affairs at Axum Therapeutics. Thank you for the opportunity to provide information on Auvelity, which is dextromethorphan and bupropion extended-release tablets indicated for the treatment of major depressive disorder in adults. Historically, oral major depressive disorder therapies have shared the same primary mechanism of monoaminergic modulation. Challenges with existing therapies include delayed therapeutic effect, low rates of remission, and intolerable side effects. The lack of pharmacological diversity among oral treatments is a known unmet need. Auvelity is the first and only oral NMDA receptor antagonist approved for the treatment of major depressive disorder and represents the first oral treatment whose mechanism is not primarily monoaminergic. Dextromethorphan is an antagonist of the NMDA receptor and a sigma-1 receptor agonist, though its clinical utility in treating CNS conditions was historically unrealized due to its rapid metabolism by cytochrome P452D6. The role of bupropion in Auvelity is primarily to increase and prolong plasma levels of dextromethorphan by inhibiting its CYP2D6 mediated metabolism. In the pivotal placebo-controlled double-blind randomized Gemini study, Auvelity demonstrated a statistically significant improvement in MADRS total score at week 6. Significant and clinically relevant improvement in MADRS was also demonstrated at week 1. No other oral antidepressant has FDA-approved labeling stating improvement in depressive symptoms starting at week 1. Furthermore, Auvelity demonstrated statistically significant remission rates at week 2. Of note, Auvelity is now among the recommended first-line treatments in the recently updated Florida Best Practice Psychotherapeutic Medication Guidelines for adults with major depressive disorder. As with all antidepressants, Auvelity has a boxed warning for increased risk of suicidal thoughts and behaviors in pediatric and young adults. The most common adverse reactions in our clinical trials were dizziness, headache, and nausea. I refer you to the full prescribing information for a complete list of warnings, precautions, and adverse events. In summary, Auvelity is a novel, oral, rapidly acting antidepressant that addresses important clinical needs in major depressive disorder and should be considered for preferred status on the preferred drug list for the Medicaid beneficiaries in the state of Oregon. Thank you for your attention, and I'll be glad to answer any questions.
Thank you, Ronnie. Any questions for Ronnie on the committee? Okay, thank you. Next, we have Nirmal Guman from Johnson & Johnson, manufacturer of Spravato. Nirmal, are you able to unmute your line?
I am. Can you hear me okay, Roger?
Yes, can hear you loud and clear, and the floor is now yours.
Wonderful, thank you. Hi, my name is Nirmal Guman, and I am a pharmacist and principal scientific account lead with Johnson & Johnson Innovative Medicine. Thank you for this opportunity to speak to you about Spravato. Spravato is a NMDA receptor antagonist indicated in conjunction with an oral antidepressant for the treatment of treatment-resistant depression, or TRD, in adults, depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior, referred to as MDSI. Spravato is available only through a restricted program called Spravato REMS. Please see the prescribing information for complete information. We appreciate that the committee has made meaningful changes to the prior authorization criteria for Spravato. And we still note that the recommended PA criteria does not allow for the use of Spravato in those age 65 or older. In the phase 3 TRD clinical program, 194 patients who were exposed to Spravato were 65 years of age and older, and of those, 25 were 75 years of age and older. No overall differences in the safety profile were observed between patients over 65 years of age and patients under 65 years of age. The efficacy and safety profile of Spravato nasal spray was compared between younger and older patients with TRD in a post-hoc analysis of the long-term open-label multi-center phase 3 SUSTAIN-2 study. Patients from both groups had a similar mean reduction in MADRS total score in the induction and optimization or maintenance phases. Serious treatment emergent adverse events were reported in 2.2% versus 1.9% of patients in the induction phase and 6.7% versus 4.8% of patients in the maintenance phase in the younger versus older group, respectively. A post-hoc analysis of the real ESK study in Italy evaluated the effectiveness and tolerability of Spravato nasal spray in 30 patients with treatment-resistant depression aged 65 years and above. Patients received an initial dose of 28 milligrams biweekly for 1 month, followed by a once-weekly flexible dosage of 28, 56, or 84 milligrams for the next 2 months. A response was reported in 26.7% and 53.3% of patients at the end of 1 and 3 months of treatment, respectively. Treatment emergent adverse events occurred in 63.3% of patients with temporary effects. 6 patients discontinued treatment, with 2 due to treatment emergent adverse events. In summary, we appreciate the updates made to the Spravato criteria and recommend that the committee consider allowing coverage for patients over 65 years of age. Thank you for your time and consideration today. I am now available for any questions.
Great. Thank you, Nirmal. Questions from the committee? Just your chance about Spravato. All right, thank you. Next, we have Linda Finch with Biogen, manufacturer of zuranolone. Linda, are you able to unmute your line?
I am. I'm unmuted. Can you hear me?
Can hear you loud and clear, and the floor is yours.
Thank you very much. So this is Linda Finch. I'm a medical account director with Biogen, the manufacturer of zuranolone. As Roger mentioned, I just signed up today because there was the minor change in the one-time use for zuranolone. So I'm just here if you have any questions. But other than that, I will yield my time back. Thanks very much.
Short and sweet. Thank you, Linda. Any questions for Linda about changes being made to the zuranolone? All right. Appreciate your time and getting it back to the committee.
Thanks.
And so the recommendations are back in front of the committee on the screen.
Do we have a motion?
So moved.
Seconded.
All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, motion carries.
All right, thank you. Down to our final topic. So if you're following along on the packet of materials, draw your attention to page 259. In past meetings, Deanna's had like 6 topics, so we gave her a little bit of a break, but she gets to put a bow on it for us. So Deanna, we'll turn it over to you for the new drug evaluation of Veozah.
Thank you, Roger. If we can go to the next slide, we'll be talking about fezolinetant. Basically, the purpose of this review was to evaluate the evidence regarding the safety and efficacy of this drug compared to placebo, and then to evaluate if there was any differences in pertinent subgroups. Next slide, please. So just as a reminder, I talked about the current treatments in the packet. Estrogen or hormone replacement therapy along with progestin is the standard of care. But for women that cannot tolerate estrogen, there are some alternatives or progestin. So there's another drug, basodoxifene, which is a selective estrogen modulator, and that's combined with estrogen. And it's indicated for women who cannot tolerate progestin therapy due to breast tenderness or vaginal bleeding. And then there's another paroxetine, which is a selective serotonin reuptake inhibitor. It's only FDA approved to alleviate moderate to severe vasomotor symptoms that are associated with menopause, but it's not indicated currently for any psychiatric conditions. If we can go to the next slide, please. So some studies have been looking at what happens when estrogen levels decline with menopause transition. And recently there was a discovery that neurokinin-3 receptor mediated activation is unopposed in the absence of estrogen, and that leads to hypertrophy of the neurons that are involved in the regulation of the thermoregulatory center and the hypothalamus, which results in hot flashes. And fezolinetant is unique because it is a selective neurokinin-3 receptor antagonist. So thus it reduces the episodes of hot flashes. Its approved indication is treatment of moderate to severe vasomotor symptoms associated with menopause, and the recommended dose is 45 milligrams once a day. We go to the next slide. There were 2 phase 3 trials, Skylight 1, Skylight 2. They were double-blind, placebo-controlled, randomized controlled trials. The placebo period only lasted 12 weeks, and then there was a 40-week double-blind extension period in which the patients just, they all received fezolinetant. There was no more placebo comparator. So there were 2 co-primary endpoints, the change from baseline in symptom frequency, and the investigators had defined the minimum clinically important differences, a change in more than 2 hot flashes per day. And then they also looked at change from baseline in symptom severity, and that was scored by patients on a visual analog scale from 1 to 3. So the differences were very minimal, as you can see. In terms of the change for more than 2 hot flashes per day, only the 45 milligram dose showed any significant differences. The 30 milligram did not meet the minimally clinically important difference. We can go to the next slide, please. So a couple of the trial limitations is we only have the placebo comparison for 12 weeks. They didn't look at any other menopause symptoms such as mood changes or sexual function. Most of the enrolled participants were white, although observational studies have indicated that Black and Hispanic women experience higher frequency and severity of vasomotor symptoms associated with menopause. The FDA reviewers did a subgroup analysis by smoking status, age, race, and body mass index. And because the trials were not powered to detect differences in these subgroups, they could not find any differences. And finally, we don't have any comparative evidence with fezolinetant compared to hormone replacement therapy or selective serotonin reuptake inhibitors. The next slide talks about the safety. So there was another trial, Skylight 4, which was a double-blind 52-week phase 3 safety study. The main purpose for this was they wanted to see if there was any risk of endometrial hyperplasia or malignancy associated with use of fezolinetant. And they did find one woman in the 45 milligram dosing group had endometrial hyperplasia. And then there was one case of endometrial cancer in the fezolinetant 30 milligram group. And you can see this was in about 1,200 patients. Uterine bleeding occurred in about 5% of the placebo group and about 3% of those that received fezolinetant. The most frequently reported adverse reactions were gastrointestinal in nature, so abdominal pain or diarrhea. Next slide, please. Other safety considerations, this is metabolized by the liver, so it's a CYP1A2 substrate, so it's contraindicated to use it with any CYP1/2 inhibitors. Also, if someone has severe renal impairment with a estimated glomerular filtration rate less than 30 mils per minute, or if they have severe cirrhosis, the drug is contraindicated. For some of the people in the trial did have elevated LFTs, so the manufacturer recommends assessing hepatic function before starting therapy and then monitoring those parameters at 3, 6, and 9 months after starting treatment, or if symptoms suggest liver injury. So if we go to the next slide, we'll talk about the proposed PA criteria. So the first 3 questions are, the first 2 questions are basic questions that we ask. And we're asking if it's a FDA, for the FDA approved indication. Question 4 is asking if they step through estrogen progestin or do they have contraindications to hormone replacement therapy. Then if we go to the next slide, we're going to be assessing basically the safety questions. So are they on a CYP1/2 inhibitor? Have they obtained baseline renal functions to ensure that they have adequate renal function to tolerate this drug? And then have they obtained baseline liver function tests to make sure that they don't have severe cirrhosis? And if all of the baseline monitoring checks out, the drug will be approved. And then we also have renewal criteria just to assess if the vasomotor frequency and severity have been reduced with treatment. Are they continuing to monitor liver function? And if so, are those LFTs normal? And with that, we'll just talk about the recommendations, which are to add fezolinetant to the preferred drug list and designate it as non-preferred with prior authorization criteria to make sure it's being used for the appropriate indication, that they've tried other treatment, and that the safety assessments have been analyzed. I think we had written commentary, but no public comment. Is that correct, Roger?
That is correct.
Any questions? I know I went through that pretty quickly.
Good job, Deanna. Any questions from the committee? Okay. Recommendation is to add Veoza to the PDL and designate it as non-preferred, and to implement the proposed PA criteria.
We have a motion?
So moved.
Second.
All right, all those in favor?
Aye.
Aye.
Yeah.
Opposed? Abstain? All right, motion carries.
Great. Well, that concludes the clinical information we wanted to present. We need to go into executive session to review confidential pricing. I need to read a blurb in my best radio voice. No business will be conducted during exec session. We'll come back out to open session and make recommendations at that time. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 192-6602F, RS 414-356-1 and 2, which allows the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with the requirements of ORS 414-353. Representatives of the news media and designated staff should be allowed to attend the executive session, and all other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session, as previously announced. No decision may be made in executive session, and at the end of the session, we will return to open session. And with that, for the committee and for our new member, just so you're aware, we're going to go to a breakout room. And the committee is returning from executive session. Bear with us a second. We have a few people who have to change lines as we're getting to the top of the hour. They have to switch, so we have to readmit them into the room. So got a few more clicks of the buttons. Everybody's in. If the committee members can unmute your lines, I'm just doing a quick head count on this side so that we see.
This is Tim.
Great, Tim. Glad you're here. We're just about to put forward recommendations from executive session.
Can you hear me okay?
Hear you loud and clear, Stacy, and I made you a host. So, all right. Definitely have a quorum plus a couple. And so we're here for final recommendations. So the first recommendations I'm going to put forward to the committee are to lump those that came from the topics in consent agenda. And I also failed to actually take a vote on the consent agenda as we generally do in open session before we moved on. So for the insulins, the recommendation was no changes to the PDL are recommended based on the clinical review of efficacy and safety. After review in executive session, the recommendation is no PDL changes are being recommended. And for the inhalers in the asthma class in COPD, the consent agenda recommendation was no new evidence is being considered, so no changes to the PDL are recommended. After review of pricing in executive session, the recommendations are to make beclomethasone dipropionate HFA, which is QVAR Redihaler, and mometasone HFA, Asmanex, preferred, and to make fluticasone propionate HFA non-preferred. And finally, for the consent agenda topics, the recommendation was to add the new FDA-approved anti-neoplastic agents to Table 1 in the oncology agent PA criteria. So let's take those three topics and see if we get a motion to approve.
Motion to approve.
Thank you, Doug.
Second. All those in favor?
Aye.
Aye.
Aye. Aye.
Anyone opposed? Abstain? Motion passes.
All right, now I'm going to take the next two recommendations for the Pompe disease class update. We are going to maintain the two agents as non-preferred, and after review in executive session, no PDL changes. And for the antidepressants, the recommendation is to assign the voluntary non-preferred status to Trazodone, Zulresso, and Symbyax, and to recommend switching patients from fluvoxamine ER capsules to IR capsules for those taking 100 milligrams or less, and that will be done through lettering to prescribers asking them to voluntarily make that switch by writing a new prescription for the members. And that's it for recommendations. Do we have a motion to approve those two?
Motion to approve.
Thank you, Russ.
Second.
Appreciate it, Pat.
All those in favor?
Aye.
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 Opposed? Abstain? Motion carries.
Fantastic. Well, that concludes the business we had for the June P&T meeting. Thank you all for your efforts and volunteering. The next P&T meeting is scheduled for August 1st. Same bat channel and bat time. So we'll be posting draft documents in about a week and a half. And with that, thank you all very much.
Have a good rest of the day.
Thank
You
you.
too. Good luck at
Thank
that. You bet.
you.
Thank you.
Thank you.